Good morning, colleagues. I am Monde Ntwasa, and I am your host today. And Prof. Andreas Kaufmann and Dr. Amanda Skepu will be the session chairs. Welcome to the second day of the launch of the Pan-African Cancer Institute at the University of Pretoria. I'm deeply honored to be your host today in this really prestigious beginning here of the Cancer Institute. This institute, if I look at the vision in the document here in the program, already shows us looking very much into the future, and it's addressing very demanding and key areas of oncology, precision oncology, and it's also looking at novel therapeutic solutions. It is, I think, the first of its kind in South Africa to use hard sciences to tackle these problems. And it's not just looking at health solutions in general, but at also the discovery of novel therapeutics. This is really exciting. I've seen in the program yesterday that this was attended by extremely eminent people around the world, and today as well. Any institute depends entirely on clearly defined outcomes, benchmarking, and experience from those who have gone the path. From what I saw yesterday, that's good footing. That the experience that we found from people who have gone down this path is going to really enrich this program. And the topics that are addressed in the program are really exciting and really show that there will be a wealth of knowledge as a basis and foundation of this. I have to commend Prof. Zodwa. I know her to be an extremely adept at creating international networks, managing research, and I see familiar people here like Prof. Bates. I don't know if he still remembers me. I haven't seen him for almost a decade, but it's good to see him here. So, ladies and gentlemen, welcome to all of you here and around the world. I'd like to introduce our first keynote speaker, and I believe he's speaking from overseas. And that's Professor Sunil Maharaj. Prof. Maharaj is acting vice principal. Merota, sorry. So it's supposed to be Merota. I do apologize for that. Yeah, sorry, it's Professor Ravi Merotra. Prof. Merotra's expertise covers the gamut of cancer prevention, state-of-the-art diagnostics and treatment. He is an extraordinary professor and member of the International Scientific Advisory Committee at PACRI. In addition, he is the founder of the Center for Health Innovation and Policy Foundation. He was, till recently, the founder, CEO of the ICMR India Cancer Institute Consortium and directed the ICMR National Institute and Cancer Prevention and Research at Noida. He completed his medical training followed by MD and DPhil and fellowship of the Royal College. His research includes cancer prevention and tobacco control, and he is in the editorial board member of 10 international medical journals. He has published more than 250 scientific articles, cited more than 23 times, and has an index of more than 50, H-index of more than 50. He won the prestigious Dr. P.N. Wahi and Dr. Lahn Awards in cancer prevention and the Ernest Fernandez Award of the Indian Academy of Cytologists and its past president. Prof. Merotra's research has helped shape the national cancer services in India. He has raised the profile of cancer among the public and policymakers. The subsequent political support has paved the way for many new cancer screening services in India, for example, cervical cancer screening program. He established the World Health Organization Knowledge Hub in smokeless tobacco, a global beacon of knowledge on smokeless tobacco. His impact on cancer control at an international level has been recognized by working as a committee member at the World Health Organization International Agency. For cancer research, he has edited or contributed to several critical global policies and technical documents on cancer. With that introduction, Prof. Merota, and I do apologize for giving you another name in the beginning, but welcome, and I hope you are in good shape where you are and you have good weather. Here in Pretoria, we are enjoying really lovely weather. I'm not sure about you though, but welcome. We're looking forward to your talk.
Thank you so much for the very kind introduction. At the very beginning, let me congratulate Prof. Zodva and her entire team for the inauguration for the last so many years of working. This is a very auspicious and I think a very welcome moment for everybody. So congratulations once again. So coming to the task at hand, I would like to talk about strengthening cancer prevention and control in Africa. As has been mentioned, most of my working career in India as well as in many other countries has been focused on cancer prevention in the lower middle income countries. So I was very fortunate to have been selected as a committee member of the scientific committee of PACRI, as well as they honored me with the extraordinary professorship, and I am obliged to them. So let me see how I can talk about some of our successes and failures while working in the LMICs. How does it relate? I'm working mainly in Asia, but how does it relate to Africa? What are the pressing problems as well as what are the low-hanging fruits? That is the thing I want to briefly touch upon. Just give me a second. Right, so let's start with the global scenario as far as cancer is concerned. Many of you are familiar with cancer in your country, but or in Africa overall. So, but when you talk about the world, it is actually quite an interesting scenario that 1 in 6 cancers, 1 in 6 deaths are due to cancer as we speak. Unfortunately, 70% of these cancers are in the lower and middle income countries, including Africa and Asia. The cancer burden is high and unfortunately increasing. And the maximum increase is in roughly 80% is in the LMICs, where practically 20 million new cases are expected every year. This is the latest figures from the WHO. When we talk about what is happening as far as the global situation, 1 in 5 people will develop the cancer as they reach the age of 75. World population is rapidly increasing, and similarly as in Africa, and we expect it to double over the next 30 years or so, and from 11 to 22% will be the problem. In poorer countries, if I may call them so, or nowadays the right word to use it is transitioning countries, many of the older people still die of non-communicable diseases as infectious diseases go down, so heart disease, cancer, and diabetes, rather than infections and parasitic diseases. And you can see from the graph on the right side how this transition is happening as we speak, and it's probably the difference is going to increase as we go further. These are the common cancers in the world at the moment. Till about 2 years ago, 3 years ago, the maximum was the lung, followed by the breast, colorectum, and prostate. Already they are finding the lung cancers are going down, especially in the West, and breast cancer is probably the #1 cancer in the world as we speak today. I will talk about the situation in Africa very briefly. So this is the transition, as you see, as we go along in 2050 or so, it is expected by modeling that cancers will be the number one killer, followed by heart disease, and then by stroke, and lung disease will actually decrease as we go along. So that is how it is expected to change. So that is the reason why emphasis on cancer and cancer research and cancer control is of extreme importance. This is an emerging crisis in Africa that needs to be addressed in order to control for increased incidence and mortality. It is expected in another 8 years' time, there will be a 70% increase in population growth. Already the average age after the HIV pandemic has gone down is roughly about 60, and maybe it's increasing rapidly. This cancers have coexisted with other communicable diseases, especially malaria, Ebola, and now, of course, COVID. Although the cancer death rates have surpassed those of AIDS, tuberculosis, and malaria combined, it is a requirement for the commitment is required for fighting cancers. So this is the latest Globocan 2020 from WHO IARC, where also I have a small part to play. And in Africa, as you can see, the maximum ASR is in the north as well as the south. The middle, they have a relatively lower, that is the good news, but is it due to not so different lifestyle as what it used to be? Is it due to poor reporting? Is it due to poor better cancer control and facilities? That is yet to be seen. So that is, I think, a fairly good way of representing it. When we talk about the most frequent cancer types in the African region, different colors talk about the north, east, west, and central. And as you can see, the north again is the deepest blue, while you have breast, cervical, liver, and thyroid cancer. In some areas, then your stomach is actually going down, and liver cancer is also going down. Unfortunately, breast and esophagus is also going down, as a matter of fact. So as we go along, we'll talk about the transition from various what it used to be 20 years ago and what it is today. There is quite a bit of regional variation, and I'm sure you are familiar with that. So there's a north-south divide, the gap between the rich and the poor, and really require radical solutions to status quo has to be changed. Recognizing that no single governmental funds or philanthropy can solve this problem, it needs to be a joint or a collaborative approach between different countries, and that is where institutions like the PACRI, which have a holistic view of different countries and the different cancer control issues, is extremely important. So there are enormous challenges as we have an increased population growth, life expectancy. We talked about communicable diseases are going down in Africa. However, unfortunately, there is little investment in capacity to fight the current problem of cancer. There's a critical area of investment, not only in financial, but also for people who have cancer. It is bad, but even worse if you have cancer and if you are poor. So out-of-pocket expenditure, poor access to care are some of the major issues which I'll be touching on today. So if not controlled, we are expecting to cross about 1.25 million cases annually by 2030. Female cancers, as I mentioned, are breast and cervical, while for males, prostate cancer is among the most common cancer. Other, of course, are liver, esophageal, colorectal, and lymphomas. Mortality related to these cancers come as a result of delay in screening, problems with accessing care, problems going for traditional care rather than medical care, and then also unaffordability of health systems. And this is, of course, not only Africa, but many parts of Asia as well. But there are some specific issues in Africa which I think can be easily tackled, provided there is a will, provided there is knowledge, and provided there is a concerted collaborative effort to do that. When we talk about cancer prevention, as I mentioned, it has to be a community-based strategy. is important that the appropriate use of preventive, for example, multi-sectoral collaborative approaches, exploration of what are the socioeconomic and social determinants which affect healthcare as well as access to healthcare and cancer risk behaviors. Looking at what are the strategies we can decrease age discrimination, because problem with the senior citizens or the elderly or the older patients are there all over the world, and I'm sure Africa will not be bereft of them. So literacy and numeracy, increasing the access and effective cancer prevention initiatives. As you are familiar, many of the cancer trials actually do not take enroll patients more than 65, when most of the patients, at least 50% of the patients, are aged more than 65. So that is something all over the world, and we are trying to do something about it. So we're talking about contributing, the efforts contribute to lack of cancer prevention and control. I mean, I personally feel that cancer prevention is probably the more important thing than cancer treatment, because treatment, especially for people coming in late stages, is like the dog chasing his own tail, proverbially. You will never reach there, especially with the levels of financial and human resources, as well as issues like cancer registries, which I'm sure are a problem. Overall, governments all over the LMICs grapple with limiting funding as well as competing healthcare priorities. Is it more important to go for maternal child health? Is it more important to go for infectious diseases? I mean, these are very moot points, and you can discuss them till the cows come home without coming to a very easy answer. So let's talk about cervical cancer. Unfortunately, still it is fairly high, and it is the most preventable of all cancers. We know the causation, we know we have a test available for it, and we have a vaccine available for it, and we have treatment available provided it is caught early. Especially the sub-Saharan countries still have a long way to go. And I talked about safe sex behavior like condom and usage and circumcision, but implementation, access, and affordability remain challenging. Investigations like the visual examination are the screening methods which are most cost effective, usually they're done between 30 to 50 years of age. However, in patients with HIV or living with HIV in high prevalence areas, it would be appropriate to start testing less than 30 years and even 20 years plus. Regarding HPV vaccination, again, this is a separate topic. I'm sure the cost as well as the availability is always a problem. But I think it is the single most effective intervention that you can possibly talk about. But of course, there are various issues there as well. So I talked about anti-HPV prophylaxis. They can drastically reduce over a period of 20 to 30 years. One could talk about is contemplating screening versus vaccination, look at cost effectiveness. Also, we can look at future cost-effective economic studies, as well as talk about specific issues like younger women, as I mentioned, 20 years and more may be worth screening, especially in HIV scenarios. So this is from a very recent paper just last year, and they talk about cervical cancer incidence and fatalities over various parts of South Africa, how it has changed between 2002 and 2018. As you can see, there's not much of a difference in the wide variation that was there in other cancers. It is not really that much of a problem. So incidence of cervical cancer per 100,000, that is the top level changing over a period of 16 years. How this evolution has changed is on the left bottom side, bottom, and it hasn't really changed except maybe over the western area, which is the top of the curve. And then the third, at the C, talks about how fatality rates have changed over the last few years, and you can see it has become relatively better as we speak. But then there's a wide variation between the north and the west. The west seems to be obviously needing more work. Another tumor was the esophagus, of the area that there are huge disparities, and you can connect it with smoking or alcohol consumption, which is seen practically in many parts of Africa. And also there's a recent importance of smokeless tobacco in addition to smoking, and 30 African countries have been studied, and the report is available in the reference below. So they differ significantly, and that this could possibly explain the disparities in the incidence rate. So smokeless tobacco is tobacco which is chewed and not really smoked. And we in India, we were lucky to host the global knowledge hub on smokeless tobacco, and they have a website which is available for anybody to can see. This is a paper, actually it came out of PACRI about a year ago, in which they compared all the lower to middle income countries of esophageal cancer. And we talked about, as you can see, as far as Africa is concerned, the ASR is definitely the worst of in the south and the east, in the west, while if you look at the east and the north, the numbers seem to be much less, especially when you compare the adenocarcinoma as well as the squamous cell carcinoma. Squamous cell, of course, is far more common. This is again the similar kind of thing as you see if you compare 2012 figures to 2018. It did show peak, especially in the southern part in 2008, but the number of cases has actually gone down, and that is the good news. When you look at the dynamics, again, it has come down the maximum in the West. And of course, by gender, you can see what's happening in male and females if you're looking at various aspects. So maximum in the southern and the eastern aspect. This is looking at the graphs. Prostate cancer, unfortunately, still remains the #1 cancer for men in Central Africa, especially. In terms, ranks before lung cancer in terms of fatality for men in Northern Africa. So this incidence has been increasing steadily. Now this could be due to better awareness, increased longevity, as well as better diagnostic facilities. In one study, you found that 80% had never heard of prostatic cancer, and hardly 6% were aware of what is a prostate-specific antigen. And the digital rectal examination, ultrasound, these are increasing with age. Again, a similar thing, you find that if you compare 2002 to 2018, the number is actually goes up higher, especially in the southern part of the country. The western part, again, you find that the numbers are going high as we go along. And basically, this is something we should be careful about increasing and what can be done. I think there's a research gap. So when we talk about what are the research gaps, most cancer preventive have been done in the western and southern parts. So it probably needs to be expanded to other parts of Africa. There's urgent need for more population-based studies, because quite often information is not there and cancer registry data is missing. We're talking about specifically African culture, which are specific policies and gender contribution. These are important, as well as healthcare, costing, as well as economic factors. Such research gaps may be discussed in the light the need to look at attitudes and beliefs. Is there a health-seeking behavior? And also importance of interdisciplinary activities between researchers, universities, and policymakers. When we talk about breast cancer, again, it is the #1 cancer in women in many parts, especially it has increased in the northern and southern Africa. In northern Africa, it has actually doubled in the last, say, about 20 years or so, and mainly explained by the adoption of Western lifestyle. When you look at nulliparity, increase in obesity, hormone replacement, nutrition, so on and so forth, while in Eastern and Western Central has remained practically stable. But the good news is that the fatality level has actually decreased. So you're doing something well here, and please keep on at it. So with this, as you see, from 2002 to 2018, especially in the northern and the southern, the numbers have dramatically increased. So is it due to better screening? Are you doing mammography? Or people becoming more aware? That is something you will have to study further. Before we end, talk about liver, because that was again one of the cancers that you can do something about, and it used to be far more common than earlier. It was highly lethal, unfortunately, with hepatocellular carcinoma. It develops relatively early, that is less than 50 years, aggressive. Once you have it, it is very difficult to treat, related to hepatitis B and C, for which at least B you have a vaccine. aflatoxins, as well as alcohol causing liver cirrhosis. So dynamics of the African population predict this burden, and that is something we are very, again, happy that it is going down a little bit. But what can be done to prevent it? Well, I talked about it. Mitigating exposure to dietary and metabolic risks. Treating, of course, hepatitis B and C. There are reasonably good treatment available now. And of course, improving cancer detection, diagnosis, and therapy. Again, to reduce, we're talking about screening, diagnosis, and treatment, and you're talking about curbing the mortality, may deliver a model which can be followed in other diseases as well. So these are the big 8. Again, talking about lifestyle, importance of diet, exercise, weight, food, and radiation, of course, then occupational exposure, infections, and reproductive factors. These are known risk factors for cancers anywhere. They, of course, they apply to Africa as well. Tobacco is still one of the most preventable causes of cancer, and as the consumption goes down in the Western countries, the much more move into Africa and Asia. Increasing cigarette consumption is a major health problem, and tobacco control awareness efforts have been blunted by the electronic media as well as the various companies, which even started talking about. I remember going to South Africa, to Cape Town, and there were electronic cigarettes being sold there in various fancy bars, and also the other newer devices like heat not burn. When the National Cancer Institute in the US, they did this study about 3-4 years ago, and they talk about what are the increasing challenges. They talk about mobilizing data, mobilizing partners, evaluating and monitoring the efforts, evidence-based strategy, and then identifying what are the priorities in that order. When you look at priorities in cancer control through an ECHO program, which again I was involved with, starting from top to bottom, it starts with the resource mobilization and going down to advocacy and closing the various gaps. So before I end, I'll just talk about what are the importance of treatment and palliation. I think research is really needed there. And ideally, this access to treatment should be there, that all people who should be treated should have that facility. Radiotherapy machines, Austria, for example, where I'm involved with the WHO International Agency for Research for Atomic Energy, there's one radiotherapy machine for 200,000, while in Tanzania and other parts of Africa, many countries have just one machine per up to 10 million. So obviously, the problem is of availability, of not being able to a non-functioning machine, as well as older machine like the Cobalt, which again may not be working. So talking about control, we talk about radiation, we talked about chemotherapy that may not be available because, first of all, the cost. Secondly, healthcare professionals may not be skilled, and also access to laboratories may not be giving blood counts and anti-emetic treatments. Many of these trials for chemotherapy are done in high-income countries. They may not be generalizable to LMICs, as well as tumor characteristics may be different. Access to treatment and number of cancer centers may also be a problem. Nowadays, more and more people are talking about personalized therapy, but obviously you should have biomarkers and making sure that you can give stratified medicine. These are expensive and not easily available. One common factor we always talk about is palliative care, especially talking about opioids such as morphine. Health workers may not be knowing about it, and they may not be trained, and it may not be accessible. So every patient has the right to painless end of life, as well as during the treatment, that is also palliation. So when you talk about the number of cancer treatment centers and pediatric oncology, palliation, this is not sufficient to cover the increasing needs. We need to train more oncologists and health professionals to have the necessary infrastructure so that this facility can be actually used as we go along. Before we end, again, talking about universal health care, I'm sure you're familiar with the SDG, or the Sustainable Development Goals. By 2030, we are supposed to be looking at a reduction in premature mortality. And for all ages, this package should be there, starting from childhood cancers to the elderly. So what has happened is the national control program in many countries in Africa, some of these countries do not have this control program, and some are not implementing it as appropriate as possible. So importance of collaborative partnerships, evidence-based cancer control plannings and mentoring, as well as technical assistance. Able to train, for example, in the UK or US and not being able to implement it in your own country is a serious problem for not only for Africa, but for every country that needs it. So lastly, what are the need of the hour? We need cost-effective cancer prevention programs, coordinations of donor funding, advocacy, education, and collaborative calls. Opportunities do exist, especially for vaccination for cervical and liver cancers, genetic testing and targeted therapy for diseases like the breast or the lung, and then a prostate, and then positive changes in lifestyle for lung, bladder, and gallbladder. So these are the things which you can easily do. When you talk about cost-effective and targeted approaches, sustainable funding, engaging the youth and policymakers, cancer prevention advocacy, stakeholders, and then making sure that lack of understanding is not there. Research is looked after. Research, and more research, I think, is extremely important in any developing country and any developing continent, including Africa. So for Africa, as it was said recently, that cancer research is not a luxury, it is a necessity. Very few resources, and that is where I think PACRI comes in very important as a role model and a torch bearer so that more data is available. You have untapped opportunities of your youth and to reduce the burden and disparities, as well as make affordable care and prevention strategies, expanding the targets to engage in the private sector stakeholders, looking at working with researchers, basic researchers, translational cancer scientists, epidemiologists, as well as various other learned stakeholders. With those words, I again like to thank you, and this is my email at the bottom. You're most welcome to mail me any help or any clarification. I'll be more than happy to do that. Thank you so much.
Thank you very much, Prof. Mehrotra, for that highly informative speech, as well as the wisdom that you have shared with us. I have noticed that a lot of the things that come foremost in your talk about prevention and screening, which I suppose are important things for us at PACRI also to consider. And you have also identified very important knowledge gaps for us and the challenges that come in front of us. But the common thread also was the factor of socioeconomic conditions around the world. That was very common throughout the talk. So, Prof, I don't know whether you would accept any questions for just 5 minutes.
Happy to. Depending on what the time allows, I'll be more than happy to answer any questions, if any.
Excellent. So while we wait for questions to come up, I was just curious to see that a lot of the cancers that you talk about were solid cancers. What is the situation about hematological cancers around the world?
Right. So basically, my talk today was supposed to be talking about more preventable cancers. That's why I did not touch upon lymphomas. I know that Kaposi sarcoma, for example, and non-Hodgkin lymphoma is more common. Leukemias, of course, especially for childhood, acute leukemias are there. But when you look at the total number, they are relatively lower. So I did not want to touch on that because I was given about 30 minutes to give this talk. But yes, I think especially for childhood leukemias, I think it's extremely important because now in the developed world, we have an 80 to 90% cure rate. And, I'm very sure in most countries in Africa that will not be achievable. And the reasons are basically three. Number one is proper diagnostic care. Number two is appropriate treatment. And I think the most important one is actually not the first two, but the third one that is the most important is the appropriate nursing care and asepsis, which is always a problem in any developing country. But I'm sure things are improving, and I hope and pray they actually improve much faster than what they are today.
Thank you very much, Prof. There are 2 or so questions, but we have to come to the podium. I'm sorry. There will be one more question, Prof.
I really wish I could be with you. It was actually a long-standing promise to Dr. Zodwa, but unfortunately, due to the COVID and other engagements, I would have maybe I have asked for a blank check to be given some point of time. I'll come and visit you guys. Yeah, please go ahead.
Okay, this is Andreas Kaufmann from Berlin Charité, and this is a debatable question I want to pose about prevention and screening. In Africa, we have a very much growing population, a larger, younger population that comes as a wave of future patients onto us. And now we have $1 to spend for screening, for treatment, or for prevention. What is the more important, and this is debatable, of course, ethically, more important way to go? Do we vaccinate for HPV, or do we build screening and treatment facilities for cervical cancer, as an example?
That's a very moot question, and thank you for asking. It's extremely important. As I mentioned in my presentation, if you just have one of the 3, that is vaccination, screening, and treatment, please go for vaccination at the present moment. The good news is that the pricing of the HPV vaccines are probably within this year or maximum by next year going to fall right down. The reason why I bring you these good tidings is that my own country in India, from the Serum Institute, that is the same institution where they're coming up with the COVID vaccine, had actually in the final stages for the clearance for the HPV vaccine. So just as happened in hepatitis B, I think HPV vaccines are going to come right down. In the UK, as you possibly know, they've reduced the number of vaccine doses to 2, and there are reports from India and from Africa that there's probably come down to 1. So if I have to choose one, I would go for vaccine. Number 2, of course, would be screening as far as possible. What we like to do is a screen and treat approach. That is when the mother is there, you screen and you vaccinate for the child, a girl child less than 13 years of age. But if you find an issue, and I know follow-up is always a problem in any of the countries in LMICs, including Africa, I'm sure. So you treat then and there, and that is where the importance of via-Willi and colposcopy and laser comes in the picture. If you don't have a laser, you can talk about cryotherapy. I mean, I can talk for half an hour, which I'm sure you don't want me to. So I think that's a very simple answer to a tough question. Everybody will not agree with it. So I think it depends. You have to tailor make your approach depending on the local situation. For example, in Africa, I understand Ghana is doing very well. Rwanda is doing very well as far as HPV vaccination. But if you look at a few other countries, I think a lot more needs to be done. And then you got the newer, more, so to say, ingenious and innovative ways of cancer detection in many African countries where they're doing a handheld device from various other parts of the world. And now I'm sure you have local people using artificial intelligence and machine learning. I mean, there is so many things you can talk about. I think we require a special session for this per se. But a long answer, sweet and short, is please go for vaccine at the present moment. Of course, it will not cover all now with the monovalent vaccine, which is probably going to be the universal soon. It will be 90 to 95%. So in spite of giving the vaccine, you still have to screen. So just giving a vaccination does not obviate the need for screening. But the interval between the screening can go up to 10 years. And there's studies from India and from various other countries where even if you have to take just one screening in a life, that cuts down your risk by 50%.
Thank you. Thank you very much. I agree completely. Very important point is the adequate method for the situation, for the local situation, to find that out and adapt the vaccination and screening strategy and treatment strategy to it. And the second point would be we vaccinate girls. Boys also suffer from cancer, and this is an upcoming threat of oropharyngeal cancer. even if tobacco consumption comes down, HPV-associated head and neck cancers are on the rise in the Western world, and it will also happen, I guess, so in the southern countries. So I would opt also for gender-neutral vaccination whenever possible. Thank you.
Absolutely, I fully agree with you. As long as your pockets allow, I think, and availability, it should be done. Thank you. That's very, very good questions. I appreciate it.
Thank you very much, Prof. Marotta, for this session. Very informative indeed. So we still have 5 minutes to if there are any more questions. Well, it doesn't look like there are more questions, so we shall move on to the next one. Thank you very much, Prof, and thank you, Prof. Kaufmann, also for the question that you have given to Prof. Marotta. Colleagues, so now we're moving on to the main session today after the keynote speaker, and this is going to be chaired by Prof. Andreas Kaufmann and Dr. Amanda Skepu.
Good morning, everybody. I would like to first thank the organizers for inviting us to this momentous occasion. And also I'd like to congratulate Professor Zoda Dlamini, PACRI, and the University of Pretoria. So my name is Amanda Skepu. I'm the Impact Area Manager at the CSIR, which is a research council based here in Pretoria in South Africa. I will be co-chairing this session with my colleague, Professor Andreas, which I will allow him to just quickly introduce himself.
Thank you, Amanda. I also am very grateful for the invitation. I'm very grateful to Zodwa to invite me here to chair the session, and I'm also grateful to the PACRI to nominate me as an extraordinary professor, which I took gladly on this task, and I hope I will get a lot of things to do. I am a biologist by training, and I'm heading a research lab at the German University Charité, Universitätsmedizin Berlin, which is a large, old, and well-recognized university. And my topic is basically since 30 years HPV research, because I graduated at the German Cancer Research Center headed by Harald Thorhausen, who won the Nobel Prize for his identification that HPV viruses can cause cancer. And this then led to screening and vaccination research. And finally, we got the vaccine and the screening opportunities we have today. I'm very happy to be here, and I'm very happy to chair this session with my co-chair, Amanda.
So, colleagues, we do have a jam-packed program this morning. So I would like to appeal to our speakers just to keep to the time, to the allocated time of 10 minutes, so that we can allow for 5 minutes question and answers session after each presentation. However, if you are unable, if we are unable to take any comments or questions, please feel free to pose your questions on the chat box, or also you can, if you are physically here, please, you're welcome to talk to the speakers directly. So moving straight to the program, I would like to call upon Dr. Tulo Mulifi, who is the specialist and senior lecturer in the Department of Medical Oncology here at University of Pretoria. Please, Dr. Tulo, come forward.
Good morning, everyone. I'm not sure if it's not yet projecting. All right, thank you. So today, as we know that not much is known about the African cancer genome in general. We really do not know what happens in the molecular pathogenesis of the cancers that we are care. So today I'll just briefly give you an overview of what PACRI has done so far and plans on doing in the future. So just to start off, we know that the global cancer burden is increasing and is becoming a real problem. Before we used to think that heart attacks were the thing to look after. Now cancer is geared up to pass those cardiovascular disease as the leading cause of cancer as the year progresses. 70% of these deaths will be occurring into low middle income countries. Where these countries are predominantly in Africa. So this is a real problem that we really need to start tackling. Just to put this into context, this looming calamity of 60%, 70% of these deaths occurring is so large that when this does occur, the high middle income countries will be able to move in and create museums for us and say that this is a continent that really could have done something but did not attack this problem. So, and obviously we've heard throughout this launch that Africa has its problems. Yes, we have infrastructural and resource constraints. However, through innovative thinking and collaboration through inter-country and international collaborators, we would be able then to address some of these resources and be able to take on the research to then discover these genetic abnormalities that underpin our cancers. We have cancer health disparities with data that we do just only reference from international studies. We know that certain cancers have low incidence in African populations through international data. However, when these cancers occur in African populations, these histotypes happen to be the most aggressive types, and the outcomes of these African populations are low. So the proven solutions through international studies has been through interrogating the patient's tumors, through multi-omics, cutting-edge technologies, through next-generation sequencing, developing companion diagnostics for these cancers, and resulting in therapies that are targeted to the drivers of these cancers. And as such, the old paradigm of a one-size-fits-all cancer regimens that are given to multiple cancers where without addressing the drivers of these cancers has now been shifted and replaced by precision oncology where the patient's tumor drivers are being targeted. And this has led to increased survivorship in international patients. So all this precision oncology has led to an explosion of drugs that are used through multiple cancers that before could not be treated. And now available drugs are now available to treat these cancers, and outcomes have improved. However, as we know, the representation of Africans in these populations, in these cohorts, in these international studies is very low. It's less than 3%. And even in those percentages, we know that we cannot generalize the genetic findings in these studies. And even when Black patients are treated with guideline therapies, Black patients still do worse than Caucasians in these trials, in many of these trials. So with this launch, we are launching PACRI as an institute that is willing to take on this fight to determine the genetics of cancers occurring in African populations and develop therapies that are specific to those mutations and hopefully improve the outcomes of our patients. So since its inception, PACRI has gone on to publish over 31 articles in international peer-reviewed journals. And this has just gone on to really lay out the landscape of all the problems that we have in this country, in this continent rather, and to show that when we do start on, when the expected lab that we're gonna have towards the end of the year, we'll be ready to hit the ground running and be able to integrate these cancers and find solutions. So PACRI has over 14 projects that have been undertaken by PhD and master's candidates. And these are ranging from multiple cancers, majority of which are occurring in histologies that happen to occur in Africans and are known to have the worst outcomes. So to conclude, cancer is a genetic disease, and as such requires its genetics to be known in order to deliver therapies that are specific to it. We need coordinated efforts within inter-countries within this continent and internationally in order to be able to spread our resources and help and find solutions that will help the outcomes of cancer patients, not only in the continent, but globally. This research, as PACRI is doing, needs to be also undertaken by Africans and to find these African solutions. We know that HIV has really, its treatment has improved, but now we need to really start focusing on cancer as a problem, because these HIV-positive patients are also aging, and with age comes cancer. So we'll be having we'll have high incidence, high mortality, unless we do something about it. So I'd like to thank you, and please do visit our website, and please donate to us. Cancer's sequencing is very expensive, and so is its therapies. Thank you.
Thank you, Dr. Tulo, for that insightful presentation, short and sweet. And it's great to see the amount of work that PACRI has done in such a short space of time, and also in training the postgraduate students. So I would allow for any questions that you might have. Yes. Yes, Ramon.
It can. There is much overlap. Right.
Can you repeat the question? Because
Oh.
it's country.
We were asked to repeat the question. So he was asking whether what you're asking is our genetic abnormalities unique to Africa in a nutshell.
What I'm saying is that I know that you want to see if it's unique to Africa versus the world, but currently what you see with COVID is that mutations that occur somewhere in Africa that can be traced also somewhere else. We have those people that haven't been traveled to Africa or anywhere else. So I'm saying, don't you think that there's no particular uniqueness in terms of mutations in cancer as compared to other international countries?
For one, there are two different things. One is communicable, the other one is not. Right? Mutations in infectious disease can get onto a plane and land in Germany and have the same effect. Cancers are completely different. Number two, on the cancers that have already been studied, the largest group is the Cancer Genome Atlas, right? And this group has shown that cancers amongst different ethnic groups have different driving mutations and prevalence of certain mutations. So it's a genetic disease and there's genetic diversity.
For instance, you already mentioned HIV as an underlying level of infection, which is maintained as a long-term disease, will lead to different types of cancer than non-HIV infections. And there are many things about the African environment which will be different. I can tell you, having arrived from the UK yesterday, it's a very different environment at the moment from what you see in Europe. It's a lot warmer than that. But those sorts of things are going to have differences that are not communicable, but are going to be non-ethnic as well.
Yeah. Of course, there are intrinsic and extrinsic factors when it comes to pathogenesis, so we'll we'll see how those play out as we go along.
The question that was posed was that the environment is also influencing the genetic background and has a contribution to the outcome of cancers, not only in the genetics in Africa. So it's my pleasure to introduce Professor Bida for the next lecture. He is head at the Department of Anatomical Pathology at the University of Pretoria. And he is in the Faculty of Science and Health National Laboratory Service, Teshwan Academic Division. It's a pleasure for me because we have both worked together in the WACA Symposium and program, which was a Belgium initiative from Antwerp to establish HPV reference laboratories, and one of this is in Pretoria here. He is also chairing the HPV vaccination and screening promotion steering committee that has been just recently established at the PACRI to promote cervical cancer prevention in this country where we have especially high rates. So please, Professor Bida, come to the stage.
Good morning. I hope I'm audible and my slides are visible. I want to thank the program director. I want to thank everybody else gathered in the auditorium. It was my wish to deliver this presentation in person, but we live in the days of COVID and the unforeseen sometimes happens. I'm going to speak today on a topic that is personalized medicine, applied in the level of prevention and screening. So it's a way of introducing this topic. We're going to look at the economic barriers. We're going to look at the case studies of emerging countries, using our country as a prime example. And we're going to look at how we can implement personalized medicine in a clinical practice, and also look at some of the values and benefits that we can reap from personalized medicine. And then we'll look at the future of precision oncology as we go. Now, the year 2003 is a landmark in terms of genetic information and genetic studies, because of the human genome sequence was actually completed. And this has started a revolution in medicine, and which is now going by the name of personalized medicine or genomic medicine. Genomic medicine aims to actually target 4 main pillars, that is predictive, personalized, preventive, and participative in terms of medicine as a whole. There is therefore a new approach in terms of dealing with pathological conditions, which is much more evident when we look at Mendelian diseases, and is gaining momentum and when we speak about cancer diagnosis, treatment, and prognosis. However, the application of the accumulated knowledge in genomic medicine has not found its full expression in some of the emerging countries. There's however, no doubt that the impact of this will increase exponentially, given that the test and the cost of genomic analysis is coming down throughout the world. Advantages of genomic medicine are very apparent. In the area of diagnosis, predictive prognosis, take an example of hematologic malignancies, targeted molecular therapy using largely TKI, tyrosine kinase inhibitors, and it's also seen in risk occurrence and investigation. For example, breast cancer using BRCA and other kind of genetic biomarkers. The application of this can also be seen in terms of the risk of occurrence if we expand that to the level of screening. This is in the area of germline mutations, for example, APC gene, P53 gene mutations, and some other Mendelian disorders. These genetic analyses have, however, not found their full expression in some of the emerging countries because of economic access barrier, ethical and cultural access barrier, intellectual capital barrier, which includes the human expertise that one needs to run these tests. Looking at the economic barriers, we see that even in the private sector, access to these tests has not become very easy to tap into because the health insurance companies have not declared universally that they would cover some of these tests. And therefore, we do need public-private partnership in terms of funding. This funding model will ensure access not only to the private sector patient, but also to the public sector patients. These can be visualized, can be realized if we start to do things like family screening for Mendelian diseases, and as well as making sure that we can start screening for those malignancies that have their driver mutations well known and established in terms of the clinical practice. Large portions of our populations cannot tap into this because of cost as a result of economic barrier. How can we integrate these personalized medicine into public healthcare system? That is the question that we have to answer, especially in the emerging countries. Using our country as a case study, we do realize that health policy initiatives have not been done in terms of the screening and prevention using genomic methods. There is no budget funding that has been considered in this case. So we do need collateral funding that will help us in terms of breaking down these economic barriers using public-private partnerships. We need to establish organizations that tap and focus on genetic research. In some countries, we have human cancer genome in Brazil, and therefore this is why PACRI, we see the PACRI in this country as a very important player in this role. It will stimulate the research in genomic medicine and help in terms of transnational genomic research that can translate into clinical practice. We therefore need to build human capital through teaching and training and put focus of genomic medicine in our undergraduate program in terms of curriculum development. And generally, every other doctor who qualifies graduates in the next few years will need some insight with regards to genomic medicine and the techniques that we're using to diagnose, treat, and prevent some of these cancers. So integration of genomic medicine in the primary healthcare level is therefore very important, because then we can start doing things like public familial screening programs to test and check for the risk of occurrence using specific genes that are unknown, and so that we can have early diagnosis, genetic counseling, and therefore we can see the benefits of genomic medicine in a population public health level. Therefore, personalized medicine should not only improve individual health status, but also improve the population health status as a whole. Implementing these will require that we look at some of the important priorities. One of them is research and development. This must be collaborative rather than in silos. This means that we need to have much more collaboration between partners nationally as well as internationally in order to have an effective breakthrough in terms of the kind of information we gather from our research project should be reasonable in terms of the sample size that we deal with. Patient involvement is also critical. This must be done with insurance that the validation of these off-the-shelf molecular test kits are actually worthy of their salt, worthy of their use in terms of breast cancer assessment. This can be done through HTA, Health Technology Assessment, Assessor, as well as the South African Health Products agencies that in fact look into the validation of these products. Therefore, equality and ethical aspects must be addressed. Access must be based on the need and not affordability. Healthcare professionals, on the other hand, must be trained in terms of their professional etiquette as well as ethical aspects. Healthcare systems should change their perspective and filter the top model of personalized medicine to filter down into the bottom strata of healthcare system. And the legal framework is also important in terms of regulating the pricing, especially in the private healthcare sector, such that these things may become affordable, remain regulated in terms of pricing, so that we can see the benefits of this in a greater population rather than the selected few. Now, the value of personalized medicine can be seen in a number of levels. At a social level, we can see that it's an attempt to actually stratify the population to target small groups based on the disease, on individuals and communities. But however, this has got a negative adverse effects because it may generate some problem of stigmatization as well as discrimination. of these individuals. However, we therefore need to have a kind of a ways and mechanism of trying to deal with this in terms of implementing and realizing the value and the benefits of the personalized medicine. Economic barriers can be broken down if we start to implement what is called differential pricing strategy. This means that the pricing of a particular agent, particular kit should not be based simply on affordability, but should be based on need. So, which means if a country cannot afford a particular drug, for example, some sort of agreement must be signed with whoever the producer is, so that it remains accessible, it remains affordable for particular countries, especially in our setting of emerging economy. We do therefore need to make sure that the availability of treatment should be there to all who need it. This means that pharmaceutical companies must have some kind of a working arrangement with healthcare providing organizations, especially government organizations, to make sure that the treatment of cancer, prevention of cancer, and so forth should be accessible to all in terms of price and everything else that goes with it. What about the ethical aspects? The pharmacogenetics and genetic screening will actually be something that is necessary, that we need to have ethical regulation surrounding it. This is because in some cases of private healthcare industry, these health insurance companies have not yet declared that this is available for all who need it because of the pricing. And often the pricing goes up, as I said earlier, on targeting these patients who have a particular genetic predisposing conditions that in fact may end up paying much more than what is necessary. So we do need government to introduce some kind of regulatory aspects by weighing the benefits in terms of credibility, adverse side effects, quality of life against the cost of these. We do need competitive bidding, which is actually in the form of ATA being involved in this, as well as setting other experienced people in the field. The more we see the benefits of personalized medicine, genomic medicine in a community level, the more we break down the cultural aspects of barriers. This is because the acceptance will become a norm if there are any barriers that may refer to the cultural aspects of these implementation. Political aspects are also important. Health equity and universal access is actually more important, and so that we can look at it in the terms that we need to demonstrate that the personalized medicine and genomic medicine does benefit the population as a whole, other than benefiting the few individuals at the top of the healthcare system. We need, therefore, to have a clear and robust evidence, which is based on and informed by research, which is multinational, multi-central, and actually based on a collaboration of a number of players in the field. There are two major areas of application in terms of the benefits we can reap from this personalized medicine. The one is genetic testing in terms of predicting the disease, which actually means screening, and as well as genetic testing in terms of predicting recurrence of a disease that is already diagnosed. We see this quite commonly in breast cancer. In early stage breast cancer, there are already testing kits that are there off the shelf that are available that can actually be done to test the recurrence of early stage breast cancer, which makes a decision very easy in terms of the adjuvant therapy after diagnosis. So one of the obstacles is that implementing such tests really requires that we have evidence-based approach and based on the information and data we can get from wide-based research projects, which are multi-central, and clinical trials that are actually multinational as well. Now, precision oncology, this is what it is in terms of personalized medicine. It has remained at the pinnacle, at the top of the healthcare system. We need to make sure that it now filters down to the secondary and the primary healthcare system. We are aware of the benefits of these in cancer therapeutics, using kinase inhibitors, monoclonal antibody treatments, and many other, such as immune checkpoint inhibitors. All these are well known and documented in the literature. But however, this is still at the top end of the healthcare system. We need to make sure it filters down to the secondary and eventually to the tertiary level, to the primary health care level, so that we can see the benefits of these in terms of the community health status of our society. Then what is the future of precision oncology? With a high throughput technology of DNA sequencing, we do know that it is centered on three main areas: transcriptomes, proteomes, as well as metabolomes. So these are the three main areas where we can see the benefits of precision oncology. However, the foundations of these are really laid in deciphering the structure, the variation, the function of the human genome as it relates to disease. This continues to give us an opportunity in order to target specific genes that are now increasing. We now have catalog of genes, increasing catalog of genes that are driving genes in terms of mutational carcinogenesis and malignancy, and these are then become targets of genomic medicine. So we need to have more of this, and then we're able to intervene in a complex array of diseases, including malignancies as well. So these genetic loci that we actually have discovered are in fact important biomarkers for diagnosis, prognosis, and treatment. Then pharmacogenetics must further develop in terms of the available repertoire of anti-cancer drug treatments. So this is actually an ongoing, and in the next few years, we'll have a lot of more of these anti-cancer drugs that will probably have many more breakthroughs in terms of treating several other types of cancer. But at the end of the day, we do need to see these things filtering down into the lower levels of the strata of healthcare in terms of a community-based approach. In conclusion, that personalized medicine must demonstrate with scientific arguments that there is a benefit for it in terms of for the community benefit in terms of preventing, prolonging life, and promoting health as a community at large. But we also need to have policymakers involved in this so that we can actually begin to integrate some of these scientific knowledge into health policy formulation. And then we need also to subscribe to multi-center clinical trials and not work in silos in terms of genomic research, because it is in fact better to have a translational genomic research that is based on a wide population other than work on a small groups of patients or individuals that are based in one institution. We need to establish, therefore, and develop networks nationally and internationally in order to realize this collaborative research project that will give us more information, more data that is much more specific and giving us much more background of decision-making in terms of intervention and treatment for cancer. Thank you. That is my presentation. Thank you very much. Shall take up any questions.
Thank you, Professor Bida. Are there any questions from the audience? And if so, please come to the podium so the virtual participants can understand your question.
Thank you, Professor Bida. It's David Bates here. Nice to see you. One of the
hi, David.
Hi. One of the key issues that has been raised in personalized medicine is that it's very expensive, and I would argue that actually it's not. It saves money, not costs money, because treating people with the right drugs, knowing when their treatments are going to come back, is economically more effective than treating them with the wrong drugs, and it not being effective. But in order to prove that, in order to get government on board, in order for the healthcare services to actually pay for it, we need the evidence for that. And that means we need to bring in health economists. And I think one of the things that I would really, all of the things that you suggest, you put up there are really important, but we also need to engage health economists to be able to model the costs of doing it, and more importantly, the costs of not doing it, so that we can show by the studies that we do that this is actually important for keeping costs down, not for increasing costs of healthcare.
Yeah.
Do you have any comment on that?
Yeah, thank you very much. That's a very good question. In fact, the whole question of access, health equity, and access and ethics and all that, it surrounds these economic barriers. One of the ways we can overcome them is to try and involve health policymakers in our research, and these research projects must be informed by them being multinational, multi-central, and once you have that kind of a situation, one of the important role players in such projects is always health economists. Health economists will be there as a part of the role players, because government will not fund, will not support projects that are not costed, that are not driven in such a way that they demonstrate unequivocally that there is a benefit in terms of doing such projects, and the findings of such projects will then filter into health policy formulation. And one of the problems, therefore, is that we do research in small silos. The research is only conducted by small practitioners, small role players who do not have economic evaluation of what they are doing. In most of the national trials that we have, most of these will include health economics in terms of evaluating the impact of this in terms of the population at large. That is very correct, and I think I agree with you. We do need them on board as well.
Thank you, Professor Bida. We are running 15 minutes behind our schedule, so I would like to call upon our next speaker, who is Dr. Langanani Mbodi. Dr. Langanani is an academic head of gynecologic oncology unit at the University of Witwatersrand. So if Dr. Langanani can come through, please.
Good morning. Thanks, Prof. Zodwa, for the invitation. You extended the invitation to vets, and we welcomed you. We do not regret not even a single day that we said yes. I'm going to give a brief talk on the upcoming project that we are going to do in collaboration with PACRI. This is going to be a project on a PhD project. Recently, in our setting, we have identified that we have had an increased number of vulval cancer patients in women who are young, less than 60 years of age. Cervical cancer and other pathologies of the vulval cancer and other pathologies of vulva were known to be those conditions in women who are more than 60 years of age. So just as an introduction, we know about the microbiomes. We know about that each organ system has microorganisms that are grouped together that serve an important function, and most of it is protective in that environment. Can you have just 2 seconds? Apologies for that. I forgot my visual aid, so I'm battling with that screen there. Okay. Yeah, we'll continue from here. So these microorganisms are known as a community, are known as microbiota, and the genes that encode them are then called microbiome. We know that the human system, or the human body, contains about 100 trillions of microbial cells and quadrillions of viruses that are found in the external and internal body surfaces, which are in their natural habitat there. And part of this is the core microbiome that controls whatever happens to the cell, whether it becomes protective, it becomes malignant, and it becomes significant. So this core, time and again, evolves. And this evolution could mean that there'll be formation of new genes, or all genes that are changing, or they're completely eradicated. And there's a lot of factors that affect what that happens. The physiology, the environment, the food or diet, the activities that we have, the pathogenesis, pathobiology, and sort of those. The bigger question is, what are the microbiomes in the vulva in general? Little is known about that, but what are the microbiomes in African women on the vulva? Little more is known on that. However, because of proximity, there's been a lot of hypotheses that because of the proximity of the vulva to the vagina, the urinary system, and the anal canal, probably there's a contaminant or co-inhibitant of those microbiomes. We know that there's about 60 to 100 units that are largely found between the vagina and the urinary system, and the subtypes overlap between those two. But the commonest that has been found and reported on most literature is the lactobacilli. The majority of it is in the vagina. So there's other bacteria that are found as microbiomes like Gardnerella, Prevotella, and Ureaplasm. So, but again, Gomesu and colleagues also emphasize that lactobacillus is the most common, and yet there's been treatment that has centered around the lactobacillus when it comes to treatment of pathologies of the vagina. So what is happening in African women? There was a study that was done by Fetways and et al. That at the population of about 1,200 African American women and about 469 women of European ancestry. So they found that the most common vaginal microbiome in African American women was a lactobacillus, but specifically the inner subspecies followed by Gardnerella vaginalis and crispus. When they compared that to women of European ancestry, they found that there was a dominance of crispus as opposed to the inners in African American women. So there is that component that we're talking about the environment where you stay in, the food types, including the hygienics, and the rest of the interaction that happens between the microorganisms, the body, and the environment that you are in. Of course, it determines what organisms should be the commons that are there. It is known that a vulva is considered in the female genital tract as the first line of defense against invasion by infectious organisms, and it protects against infection in this genital tract. The microbial growth and species imbalances are influenced by the environment in the vulva. So which means that because there's a labial folds, which increases the sweating and the humidity and the warmth, so those could play a role in what organisms are predominantly there. So any change in that ecosystem might lead to fluctuation or changes in the microbiomes that are there. It is well known that each organ system has its own microbiome specific to it, although there could be an overlap because of either contamination, proximity, or other evolutionary changes that are happening in that organ system. So microbiome in the vulva have been described in literature, but there's nothing much as compared to other organ systems that are there in both male and female. There's a big gap or a lot of gap that we still need to fill in regarding microbiome of vulva in general, but specifically in African women or African population. By African here, we are relating to African women who are residing in Africa, because it is known that the environment you are in also alters what is there, plus the diet, plus the other factors that are surrounding it might affect how those organisms could look like. So our study intends to end to the body of literature that we know that is lacking on the understanding of the microbiome in healthy women, African women, in the diseased vulva, which includes both the non-malignant and malignant vulva. But now looking at this is my apologies, I forgot to take you through with me. Looking at this slide here, you can see that when you talk about the core microbiome, whether be it intestinal, other organs, the gut, the oral, the skin, they are the ones that affect and they determine the outcome and the healthiness of the body that they are residing into. If there's any dysbiosis in those microbiome, you have a change in expression or overexpression of those genes. That overexpression can lead into cancer or complex diseases that we know. So, but we know that it's possible to restore or create restoration or modulation. There's been a use of antibiotics, postbiotics, prebiotics, and of recent there's been fecal microbiome transplantation, which is done in general surgery and has been done very well with success. So from this slide, you can see that, yes, the microbiota is influenced by diet, lifestyle, and yes, genetics also play a part, which is why we need to understand the genetics in African women, which their diet and lifestyle is different from other women where there's a lot of studies that have been done. But the exposure to prebiotics, probiotics, and treatment methods on those women who are normal, we do a swap and scrape, and those women with a pathology already, because they would have had a biopsy that is done, we are going to use the specimen that is for biopsy. For patients with malignancy, we'll have both a biopsy and therapeutic surgery that is done. We use that specimen to sequence the bacteria so that we can see the RNA gene and isolate these microbiomes from there. And then we'll do molecular testing using the common NGS chips that are available or what is currently available in the moment or what we can afford. And then with that, we'll also include doing the colony counts with all the studies that are done. In conclusion, we will say that most recent technologies that are there are based on the knowledge and scientific understanding of the microbiome, which is the evolution of understanding the pathology and how we derive therapy, how we augment the current available therapy. So that information on understanding of these individual genes and their species is very important. We aim to fill that gap specifically in African women with regard to the vulva, in both postmenopausal, premenopausal, HIV-positive women, and women with medical and oncological conditions. So this study will offer an opportunity for the development of microbiome-based therapy for different disease profiles, including immune diseases, cancers, and cancer prevention. And we hope that this will be the beginning of us to understand further and study further and predominantly base the management of all vulval pathology on what we'll find in our studies. Thank you.
Thank you, Dr. Mbodi. Unfortunately, we don't have time for further questions, and therefore I'm introducing the next speaker. It is Professor Shingai Mutambirwa. He is head of Department of Urology at Dr. George Mukari Academic Hospital and Sefcaro Makato Health Science University in Pretoria, South Africa since 2008, and he holds this position. What I found interesting in your CV is the contact to industry, where you are sitting in advisory boards, and this is quite very important to link research to translation into industry, and I commend you for that. Thank you.
Thank you so much, and it was a real pleasure and honor to be invited to give a talk at this illustrious launch. I'd like to say it's a pleasure for me to finally meet Prof. Dlamini, because we've actually done research together, but we've never actually physically met, which I think is part of this whole thing that's going on. And I think as we're starting off PACRI, I think it's important for us to remember that we have to have value and reputation maintained. And because there are two urologists in session, me and my big buddy, Prof. Matabe, I thought I would take a little bit more of a philosophical look at how we as researchers can improve and maintain our research potential. And with that, I'm going to be using mainly the vignettes from my experience with PSA screening. First of all, I think we have to remember that we need mentorship. Why I'm putting up this slide is that a number of the slides in my presentation were from a presentation done by Pat Walsh, one of the leading urologic cancer researchers internationally. He was one of the developers of the radical prostatectomy. And I think it's important for us to remember that we have to respect the past, but we also have to look forward to the future. And his speech, his talk in 2012 actually stimulated me to get more into research about prostate cancer. And I think if we can mentor people through PACRI, it's going to make a big difference. We also have to start recognizing that the media is out there. There's WhatsApp, there's Facebook. We have to get involved. Most of the data, the stuff that comes out is usually negative information. That's the one that's promoted the most. But we need to start pushing more so that we actually improve both the information that's given to the general population. Because remember, what we're doing here is really trying to improve the health of mankind. So we have to recognize that we are going to be interacting with media, and we can't just base it on the negatives. We also need to have thought leaders, and Bert Vogelstam, which you know is one of the co-investigators who picked up TP53. He said around the same time as the United States Preventative Task Force was saying that PSA screening was given level D for evidence. In other words, you shouldn't be done. He said that that what we should really be thinking about is detecting and preventing cancers at the stage when it can be cured by conventional methods, surgery, radiotherapy. In 50 years, 3/4 of cancer deaths will probably be gone, but most of that decrease will come from better prevention and early diagnosis. So we have to remember to start pushing the boundaries so that we try to get our patients seen earlier and treated earlier. So to look at that, it does early diagnosis and treatment actually make a difference? First of all, does PSA testing save lives? And with that, we use comparative trials, for example, PIVOT and Scandinavian SPCG trials. I think it's important to remember as researchers that there are always two things we must say, which we should never say, and that's always and never. There's always evidence both for and against a lot of the things that we're doing. We have to be pragmatic and understand how we can integrate both those parts. Because does PSA testing save lives? Can PSA testing do more harm than good? Both of them are yes and no. But we must also remember the differences when we're discussing things such as screening. And my viewpoint is that public health, where it's the screening of the general population, is probably not the ideal for most of us of Africa at the moment, partly because of cost, partly because of the fact that we might not be able to get everybody treatment. But more patient care, individualized picking up of patients with cancer, including prostate cancer. So, does PSA testing save lives? Truth of the matter, it does. We know that when PSA was introduced, it actually increased the number of localized prostate cancers and decreased the distant stage disease. And another point we remember, because we always like to think that we're the best at what we're doing, we as surgeons think that we are the ones who actually helped to make the decrease in prostate cancer deaths increase. In reality, we must look at the data. Nerve-sparing radical prostatectomy did not start the drop. It was actually PSA testing. And we have to integrate all of these things so that when people are discussing policies, they understand that there are different aspects that are going to have to be addressed when we're looking at patients. Does PSA testing save lives? No. We know that the PLCO trial, prostate, lung, colorectal, and ovarian screening trial, it had no effect, but there was a lot of flaws in this as well, and that has to be addressed when we start looking at our own research. The RSPC, that's European prostate cancer screening, did have a reduction in deaths. You needed about 1,000 to reduce the deaths by 1.5, to decrease 1.5 deaths. And it actually was significant in the RSPC. But the biggest problem with both of these, which were started about 20 years ago, was that they were looking at deaths at 10 years. And we have to remember that different cancers are going to have different aspects that need to be dealt with. We know that when it comes to prostate cancer, we shouldn't be looking at 10-year survival. We should be looking at least at about 20-year survival, because it's a very long cancer progression that happens. And so each cancer, each of our researchers has to base it on our own individual topic that we're looking at. Can PSA testing do more harm than good? It seems to do some good. When you look at, for example, the decrease in metastases, cancer deaths, when we started doing radical prostatectomies after PSA, it's impressive. And yet, when you look at a trial from America, the biggest trial for intervention for prostate cancer in the States, it did not seem to reduce all-cause mortality and compared with observation. But again, when we're looking at our research critically, we must remember there's so many different aspects of the statistician, the way we are interpreting our data, whether we have a positive or negative trial, whether we're going to publish our positive or negative trials. It's important for us to look back and assess what we're doing. Because in the reality is, when you look at the absolute results which were different, the relative benefit was similar. So the whole point is that you shouldn't be basing the decisions for specific interventions or screening policies on just one aspect or one trial. Again, when it comes to us in Africa, we need to start looking more at our guidelines. For example, the AUA guidelines, which is one of the top bodies in the world, very rigorous, it doesn't recommend routine screening in men between 40 and 54. And if we just adapt that without recognizing at the bottom that Black patients are far more likely to develop prostate cancer and far more likely to die from the prostate cancer, we'll be doing our populations a disservice. Similarly, the guidelines are saying that you shouldn't be doing routine PSA screening in men over the age of 70 with less than 10 to 15 years life expectancy. But some men who are older are in great health. We must be basing our decisions, both for trials as well as for treatment, not only on chronological age, but on the physiological age of our patients. And again, when we say no 70, we must remember that 50% of prostate cancer deaths occur in men who are diagnosed after the age of 75. And we know that when there was stopping of PSA testing, there was an increase in metastatic disease and prostate cancer mortality. In addition, there's more to life than death. Mortality as the only endpoint is not sufficient. We know that when we're doing trials, we don't often measure the impact that's going to happen on morbidity, life expectancy, family life, how long the person is going to be a provider. It's important to recognize that we're not just only going to do overall survival or radiographic progression-free survival. So what would I do? And again, each person has to make their decisions, but it has to be based on pragmatic information. Men with 10 to 15 years lifespan who don't want to die for prostate cancer, those are the ones I'm going to be looking at. How do we improve it? Avoid screening men with limited lifespan, avoid treatment of men who do not need it. Active surveillance is a big thing for prostate cancer now, and refer men to high volume centers. We can't all just be doing everything for all of our patients with cancer. This gets even more important as we're looking at the treatment landscape, for example, with prostate cancer, where we're losing more and more towards the left, where we're initiating novel treatments early in the disease. And when you look at some of the costs of some of these medications, if we don't do screening and we don't pick them up early, we're going to be putting them on medications which may actually break the budget of a lot of our developing countries. So finally, I think it's important that we have to include our patients. Research is great, but we need to integrate aspects from our patients. We have to have decisions together. We can't just be telling them that just because the PSA is a great thing, that's, if they don't want to have it done, we must not be forcing them. We just have to express to them, but we also have to use our research to actually make positive outcomes for our patients. And with that, I hope that we should be able to get better risks and benefits and make decisions for ourselves as researchers, as well as to make sure that we actually treat our population and people, particularly in Africa, when it comes to PACRI. Thank you very much.
Thank you, Professor Mutambura. Unfortunately, we don't have time for further questions. If you have any questions, please feel free to pose them to him during our break session. So our final speaker for this session is Dr. Khomotso Mathabe. She is the head of Department of Urology at the University of Pretoria and Steve Biko Academic Hospital, where she is responsible for clinical and research training of undergraduate students and urology registrar. I would also like to highlight that Dr. Khomotso was the first woman to qualify as a urologist at the University of Witwatersrand and the second Black woman in the country. So outstanding achievements there. It is a pleasure to have you here. Please come through.
Okay, hi everybody. The new word that Prof. Dlamini used yesterday of Pacrinians, I am one of those. So thank you so much for the opportunity to be able to speak. And Prof. Zodwa, we really are so proud to be a part of this. You've done a lot of hard work over the last 2.5, 3 years. And for this to actually be manifest is an amazing thing. Thank you for your leadership. Okay. So also, it seems that urologists are in philosophical mode. So following on Prof. Mutambura's talk. Not sure the clicker. Excuse my voice. Okay, where am I pointing this to make it move? Okay.
So next slide is there.
Sure. All right, please go. Okay. So my talk is on Afrocentricity. And I have found this so interesting just in getting ready for today, in being a member of PACRI, in speaking to registrars. What is the point? Thank you. Okay. Okay. So we could go into, there's actually 10 minutes is not enough to talk about this. I would love to talk about this all day. I really had such fun really delving into this and immersing myself into the space. And why? Why actually even look up the word and find the word and read up on what it means and what it's all about? And I think for me, this is really about giving ourselves permission to centralize ourselves. And I love that a few of the other speakers have actually alluded to that either directly or indirectly. We need to give ourselves permission as African scientists to centralize ourselves. I cannot do things that they're doing in Austria. You know, if they have got one radiation machine for every 200,000 patients, and we've got parts of Africa where there's one for the whole country, or parts of Africa where there is none, there is just no ways that I can look at African problems through a Eurocentric lens. Okay, so that's how I started looking into this. And there's various people who've been involved in the development of the concept. Was it a knee-jerk reaction to the oppression of Black people? There's, all of that we can get into, which we won't. But it started as a concept in the 60s in the States, and it was just moving through, and eventually it was sort of popularized by Molefi Kente. So my approach is going to be defining the key terminology within the space, and then looking at what, so what, now what, and then, of course, the role of PACRI. Okay. So there's Molefi Asante. He is the big guy that is quoted, the guru in this space. He didn't start the whole concept or the movement, but certainly a lot of the literature is ascribed to him and his thinking around this concept. He talks about the 5 characteristics of Afrocentricity. He argues about Afrocentric versus Afrocentrism. So, as academics, as intellectuals, we do get into these spaces of robust engagement and pedantics, right? So the semantics of it, Afrocentricity versus Afrocentrism. And then the research methodologies. So in reading up on Afrocentricity, the CSIR, and Dr. Skepper will correct me if I'm wrong, but in reading up, the CSIR recognizes, I think it's 17 research methodologies that are priority research methodologies, 6 primary, and I think 9 or 10 secondary research methodologies. In reading up, I've come across 7 other ones, and there's no time to go into that, but in the reading up, finding that from the humanities, and I mean, I don't read stuff in the humanities, it's always the hard sciences, but within the humanities, they recognize Afrocentricity as a research methodology, so as a lens through which to review whatever the data and the experiences that we're looking at. So I found that very interesting. So it felt like it legitimized, which is a little bit concerning. Why do we actually need, people legitimizing our thoughts and our perspectives and our experiences? But for those of you that do need it, it is there, okay? Legitimately, Afrocentricity is a lens through which we can look at our own circumstances. Okay. The definition of key terminology in terms of Afrocentricity is centralizing ourselves. Okay, we are important in how we look at things. And it is important that we are the ones who understand our own paradigms. It was Mr. Msomi yesterday who talked about research on the one end and the solutions and products that come out on the other end, but that those solutions and products have got to be within the paradigm of the space that they are in. And also Prof. Bates yesterday mentioned about how the solutions that we come up with must be local, okay? It doesn't help that we are looking at circumstances outside of where we are. We can learn from that, and that's what intellectual engagement is about. So we don't discredit and discard everything else that's out there, but we have got to localize it to our circumstances. And I'm going to give a very specific example in a minute. So this is about taking agency. This is about us saying, okay, these are our circumstances. We understand our circumstances. We understand the science that is out there. How do we then internalize and localize to our particular circumstances? So within the African American space, Afrocentricity being the term that they use, but I mean, we could easily have called this Ubuntu or Ubuntu. This is what we do and how we do things. We could get into a debate as to who is African or what is African, but for me, it's like whoever is promoting the best outcomes of the people on our continent. So if you are doing that which is necessary for our best outcome, then, you know, you're in, okay? And there's been comments about how, you know, Afrocentricity, in reading up the opponents of Afrocentricity who are talking about, is it anti-Eurocentric? And just that statement, okay, if you are saying, is it anti-Eurocentric, you are saying that Eurocentric is the thing. So if you feel that you as European are welcome to centralize yourself, why do you have a problem with me centralizing myself, right? So what about Afrocentricity? Why are we making a big deal of it? Well, we have a lot of problems. We need to acknowledge those, but we also need to recognize that we have got the intellectual capacity, and where is the will, and where is the scientific rigor to actually address these things. So that's where we need to go. But it's not just a health sciences problem, right? All the other, you know, all this talk, the VC yesterday, multidisciplinary, interdisciplinary, it doesn't help that I recognize that, you know, there's a problem with the water source and that is what's causing the patients in a particular village to be having cholera. I can't sort out a water problem, right? I need the municipality, I need, you know, the civil engineers. So we've got to definitely, this also has been said a lot, move out of those silos. We have got to start working with each other in different disciplines. Yes, we have the resource, human and infrastructure resource problems. We've got to learn to articulate our problems in the language of science, because it's through the language of science, that's what we've learned, right? That's what we went to school and learned how to do. So let's articulate these problems in the language of science so that we can figure out in the language of science how to solve our own problems. In South Africa, and most certainly in the rest of the world, in the US in particular, lots of harm done in the name of research. Okay, the Sims speculum, the Guyanese amongst us, just starting there. Sims was not a good man, right? The things that Sims did were not good, but we have our own issues. Dr. Death in South Africa, that was not good. So research does carry certain, you know, connotations amongst our people. And that's why we need to be the ones that are getting into those spaces and saying, you know what, I'm doing this for our good. And what do I mean by our good, right? So we need to get buy-in from these communities that we say we're serving, right? This paternalistic attitude that we bring to research cannot be continued, okay? It will not serve us well. And if it does not serve us well as researchers, it will not serve our patients well, who we're trying to serve. Whole bunch of intellectual capital that is untapped. Big data, African data, this is why we need African researchers in those spaces, because African data, all sorts of things African resource minerals, African, you know, cheap labor, African, lots of things African have been exploited, right? And we need to now be the people that are now going to guard against this. We need to make sure that we are in those rooms where those conversations are being had. We are upskilling ourselves to be able to represent our people well, to be able to represent our continent well, okay? And then, yeah, not enough time to get into this, but this pathology-based cancer registry that we have is not working. It does not inform our situation well. So if like, I don't even know what the latest stats are, I think it's like 3,000 or 4,000 people or whatever who had prostate cancer in the last survey, according to Stats SA. First of all, there's just no ways in a country this big that only 4,000 men had prostate cancer, okay? And if you look at that, about 3/4 of those are white males. And the narrative around prostate cancer around the world says how absolutely terrible it is in black people. And yet in South Africa, where we're 90% black, suddenly it's that much worse in white people. Our cancer registry speaks to access. Our cancer registry speaks to people who've got access to a urologist to do a biopsy, because only urologists are doing biopsies. There's very few biopsies, prostate biopsies, that are being done by people who are not urologists. So all that our cancer registry is telling us is that who has got access to a urologist. It's not telling us who has got prostate cancer, right? So there's lots on the landscape of stuff that we need to figure out. And so the so what is that we can't solve our own problems because we haven't even defined them. We don't even know what our problem is. We don't know the scope of our problem. We are unable to articulate our problems. So that's what PACRI in part will be doing is about capacitating us to be able to have the words, the numbers, the statistics, to actually really meaningfully engage. Okay, so now what? So in that first column, it's the challenges as I read them on the last page. But then the possible solutions. These solutions have got to be African. Absolutely collaborative work. There are amazing industry partners. There are amazing international partners. There are amazing global partners that we need to work with. But it does not help that, you know, somebody in Germany sits there with some fancy, fancy stuff, and I'm sitting here in my clinic where I don't have anything other than, you know, maybe 2 tablets of ADT. That doesn't help me. We need to form partnerships, but we need to be looking at our circumstances and defining them for ourselves. The multifaceted problem, like I said, has got to have a multifaceted solution and interdisciplinary. We've got to start to see research as a tool of healing. Research has been used as a tool to cause harm, and research has been used as a tool of exploitation. We've got to really rework this space and see how we can do so that it's actually for the benefit of the people that we say we're working for. The infrastructure and human resources limitations, thank you, Professor Ottawa, you really are trying to come into that space to just beef that up. Private sector support is also going to be very important. The partnerships in this space are going to be very important. University is working really hard to build capacity. Our Deputy Dean of Research, Prof. Mashamba Thompson, has come in really with an attitude of really trying to help in the Faculty of Health Sciences to create spaces that allow people to get the skills that they need, because we're great clinicians, right? We operate well, we look after our patients well, but we really are lacking in the research skills, and there is an absolute need for capacity building in that space. Intellectual capital untapped. I know that this evening, Dr. Matebola, the CEO of Steve Biko Hospital, will also be speaking. It's important that from the Department of Health perspective, that they understand, like right now my workload is just like unreal. I actually cannot do half the things that I'm meant to do. And so it makes it very difficult to teach well, to, you know, operate well, to do my own research, all these things. So we do not have enough staff to deliver what we need to deliver. And part of that is that we're not training our young doctors well enough and creating a space that makes them want to stay. They look at us, we're haggard, we're exhausted, and they're like, no, right? So we need to create an environment where the people that we're bringing into the system, we create a system that actually they want to stay in, because the more of us there are, the more we can actually cover all these various things that we're responsible for. And then I said about the population-based registry. So the role of PACRI, I think, has been described very well, and I won't go into the detail with that, but just to really emphasize the importance of the PhDs that are coming through the pipeline. I think that's just the first step of capacity building. Those PhDs that are coming through the pipeline are just the beginning. We've now got to bring in more of the younger people into the system, and how do we move forward with them? And those that are then done with their PhDs, the postdocs, what happens to them? What spaces are they going into you know, industry in terms of advisory boards, in terms of bringing, you know, technology home, all of those things into the innovative spaces. Prof. Senko Buge yesterday spoke about scientists, you know, creating businesses, that it's not just, you know, you're going to sit, you know, with a clinic of like 60 patients and you can't even think straight, but how do we move beyond that, that the lessons that we're learning, that our patients are teaching us, how do we actually move on to be able to serve them better by moving along this food chain? And that's the last of my slide, but I'd like to just finish this on a little bit of a personal note. In this week, I've had exposure, contact, conversations, whatever, with 2 relatives. I mean, the only cancer I see is luckily within clinic when I'm in OPD. But in this week, I have had 2 relatives, one of whom was found to, she was admitted last week at Steve Biko. Prof. Malodi's team, you know, saw her. And she's been admitted with an inoperable head of pancreas cancer. So she went to theatre last week, and all that they could do was just to do a bypass to give a little bit of symptom relief. And then yesterday, I got word that another relative, young person, 31 years of age, has been diagnosed with myeloma. So cancer is real, And it is up to us as you know, young African scientists to be paying attention to this and finding the solutions that our continent so desperately needs. Thank you so much. Is there time for questions or not?
No, unfortunately not.
Okay, brilliant. Thank you.
Dr. Matave, thank you very much for your personal view and for like a comprehensive view on what the PACRI will have to do in terms of an Afrocentric vision for education, research and treatment and promoting the health of Africans from an African standpoint of view, from an African basis. I'm very thankful for these words. Being a European, I have learned a lot. And now we have a lunch break. We start a little bit late, 12:10. We reconvene, despite that, at 1 o'clock to go into the next session. Thank you.
Before the lunch break, we've got some gifts for you and Amanda. Do you want Professor Zodo to give them a gift yourself? So, ladies and gentlemen, so we've taken about 15 minutes from our lunch. That means that we now have 45 minutes for lunch. Let's be back here to start at 1400 hours. 1400, 1300, yeah. What time we starting?
Okay, great.
Good morning, colleagues, and welcome to the second session of this afternoon. And this session will be chaired by Professor Tabe Matsibatlela, who is from the University of Limpopo. Unfortunately, Prof. Liselane Mampuru couldn't make it today because of some unpredictable events that happened. And the other co-chair will be Prof. Doreen Ramkhula Masire. I hope they are both here. She is from the Department of Obstetrics and Gynecology at the University of Botswana, Gaborone. So I want to introduce our keynote speaker this afternoon, and that's Dr. Melinda Davis. Dr. Davis completed her degree in biological sciences at Albany State University in Georgia, followed by her PhD in molecular genetics at the University of Georgia. She's a molecular geneticist trained in classical genetics of model organisms for basic science research, including mutation screening for gene function discovery. She is also trained as a genomicist in functional genomics and systems biology in model organisms and human genomes for translational cancer research and health disparities. Her work has included the discoveries of DARK, regulated immune responses, and its relationship to an African-specific or evolutionarily selected allele called DAFI-null, where the expression of the gene drives the tumor cell infiltration of immune cells in breast cancers, and all subtypes was discovered. Her publications include identification of distinct heterogenic subtypes and molecular signatures associated with African ancestry in triple-negative breast cancer using quantified genetic ancestry models in admixed race populations. Also, atypical chemokine receptor 1 in breast tumors is associated with survival. Circulating chemokines, tumor-infiltrating immune cells, African ancestry, and investigation of triple-negative breast cancer risk alleles in an international African-enriched cohort. She has received numerous honors, including NIGMS Graduate Student Research Award, NIH, that is National Research Service Award, Howard Hughes Gillian Fellow Advisor, Cornell Research COVID-19 Initiative Award, Weill Cornell Medicine Dean's Diversity and Health Disparities Faculty Award, etc. She has served on several boards and panels, including NIMHD, Special Emphasis Panel Basic and Applied Biomedical Research on Minority Health, AACR Science of Disparities Think Tank Panel, and currently the NIH-NCI Patient Engagement. Also in Cancer Genomic Sequencing External Advisory Panel, in her role as Scientific Director of the International Center for Study of Breast Cancer Subtypes, she founded by another pioneer of cancer disparities research, that's Dr. Lisa A. Newman, MD. Dr. Davis oversees research directives and capacity building efforts across our African, Caribbean, and United States sites. The goal is to establish sustainable research programs and guide study objectives for research abroad. this is quite an illustrious profile, Prof. Davis. And welcome. I'm assuming you're speaking from Georgia.
Yes, I am actually in Georgia. I'm visiting home, but my job headquarters is in New York now. Yeah.
So you're in the East. Is it in the morning or midday there now?
Oh, it's early in the morning.
Early morning. I'm sorry to wake you up, but welcome to South Africa. We've been looking forward to your lecture, and I'm going to hand over to you now.
Okay, wonderful. Thank you so much. Thank you to the meeting coordinators, Dr. Zodwa. Congratulations. It's been a phenomenal meeting. I've learned so much, very important conversation so far. I'm going to start sharing my presentation now. So give me just a moment. Okay. I assume that you can see my presentation. Okay, wonderful. Just a moment. Okay. All right, so today I would like to talk about how in our International Center for the Study of Breast Cancer Subtypes, we certainly have one of the goals by virtue of the work that we do being advancing precision oncology. By obligation, here are my disclosures. Beautiful picture of Dr. Newman. I don't have to spend much time on this slide. Typically, sometimes when I speak to students, I give them a sort of snapshot of all the things that I do currently. I'll simply add a couple of things that I think may be relevant to this particular audience, which is that I am a senior editor of the section of Disparities and Equity in a new journal called Cancer Research Communications. It's an open access journal from the AACR. And so all of the scholarship that typically gets editorial rejection from some of the more high impact journals, it is my duty to make sure that we have higher visibility of the important work that we do. So consider the journal if you're working on getting published. All right, so ICS-BCS, I serve as the scientific director. We have this sort of bifocal vision, if you will. The clinical focus is Dr. Newman's job. She's the medical director. She's engaged with partnering with the healthcare facilities that help us carry out the work that we do. And myself, as the scientific director, primarily my goals are to make sure that we have sufficient capacity building whereby the investigators who we work with are also able to learn how to conduct a lot of the work that we're currently doing. Give me just a moment. I'm sorry, having a bit of a technical issue with the Zoom window in the way. Okay, I think that's better. Okay, so I would like to talk more about the translational development. Here are some of the ICS-BCS accomplishments in the last year. We worked closely with professional organizations in the US and in Africa over this last year, especially Aortic 2021. Dr. Newman was on one of the scientific boards, and I've also presented educational workshops around genomics. This is sort of a snapshot of the publications that we've conducted over the last year. So between 2020 and 2021, this was sort of my update to our consortium at our annual meeting. And I just want to make note that we also make sure that the investigators at our international sites, particularly in Africa, are part of the authorship and our funding sources when we are lucky enough to be funded. This is a snapshot of our current research recruitment population. We're heavily based in the New York City boroughs. This picture basically exemplifies, for instance, the race and ethnicity diversity, general broad terms, but we certainly dig a little deeper. And then we have about 5 different sites across Africa currently recruiting prospective breast cancer patients and healthy women who are being screened actively, for instance, in Ghana, into our International Breast Registry. We partner with primarily Tomfanochi Teaching Hospital in Ghana, and St. Paul's Millennial Hospital in Ethiopia. Now, mainly what people see is a product of the work, or of course, our grants being funded, reports that we put out with organizations and our publications. But underneath all of that is the tremendous team effort that requires any number of all of these different aspects, from ethics and protections, biospecimen harmonization, and the QC standards that are required for the types of genomics work that we do, developing models that can help feed other scientists. And then also just the day-to-day management of big data sets, as well as the logistics of actually shipping samples, for instance. And all of these things cost a lot of money. So we have to be very strategic and creative about how we fund it. This is a snapshot of some of the partnerships that we currently have from various funding sources, including the New York Genome Center in New York, the Englander Institute for Precision Medicine. We have NCI funding, as well as a private industry grant from Genentech. I'm not going to walk you through this. It's just, when I talk about the research, you don't understand sort of the machine that's behind all of it. We actively collect saliva, blood, and formalin-fixed paraffin-embedded tumor material from all of our sites. We're also collecting from a select few fresh tissue for ex vivo organoids. This is a breakdown of some of the enrollment from, for instance, Ghana. We're tracking ethnicity and tribal affiliations as well, because we are very interested in not only the genetic background, but also, of course, social constructs as well. This is just a snapshot of the recruitment effort over the last year in Ghana. I would say it's a little shy of the numbers that we would normally see. Certainly, some of the dips are either correlated with, for instance, holiday seasons, or when COVID struck, the site shut down for several weeks. And so we're still recovering. I want to just take a moment to really highlight the fact that, we have boots on the ground. We actually come to Africa with the intention of capacity building. We teach courses, sort of like grand rounds, if you will, to the medical staff and students when we're on site. Dr. Newman also performs surgical procedures, and she also participates in tumor boards. And as an example of what we're able to do, this is just, again, a snapshot. It was part of a publication led by one of the surgical oncologists at Confanochi, showing how over time, because of the workshops and fellowships that we funded to have, for instance, the Department of Pathology personnel come visit us in the US, but also we bring pathologists on site to help augment their capacity to do, for instance, hormone receptors testing. And so what I'm showing you is the rater agreement, if you will, of estrogen receptor testing over time. And so what we find is that we've certainly started to increase the rater agreement. So therefore the capacity of these sites to actually accurately subtype, for instance, estrogen receptor status. And that's a huge impact on just the clinical operations there on the ground. As far as lab resources, I actually come and I trained our lab technician. We provide equipment to the site there. And one of the things that, this is Richard, he is able to now process all of our blood tissue. We also do, for instance, infectious disease screening. So we provide the reagents for these screenings as he then processes blood samples, for instance, for plasma and also germline DNA. So given him as official certification to do fresh tissue specimen processing for organoid development, which then becomes part of a pipeline for precision medicine. And I'll give you a little snapshot of some of the work that we've actually accomplished.
Prof. Davis? You're probably muted where you are. Can we see somewhere?
Been in the room, sort of like my colleague in the previous talk, where, currently in the U.S. we are facing sort of, well, I feel sometimes I'm in the crossfire of, more attention being paid to racial disparities, but then also the outrage of the abuse and atrocities that have occurred for the sake of science in this country and abroad. But I think it's important that we don't lose sight of the real intentions of coming towards healthcare justice, right? So we know that our underserved minority populations are severely underrepresented in research, but when they are represented, it's usually, some type of scandal, right? So what we're trying to do is right the wrongs. We have to first address the fact that there was very ill-defined research that led to the propagation of stereotyping and implicit bias, racially tailored clinical practices that were standing on very flimsy data. And so we're coming back and we're re-educating ourselves about what are the proper tools. We need to look at both biological determinants as well as social determinants that link what we see in the clinic in a systematic way where we can re-educate our students and then alter clinical practice so that we can reach healthcare justice by applying what I call culturally accurate measurements and diversity competent evidence. And so when we talk about racial disparities, especially in the United States, we know that US Black patients have the poorest survival rate in nearly all cancer types. We know the socioeconomic status is certainly linked to survival because your ability or accessibility to curative therapy is certainly hand in hand with whether you survive a cancer diagnosis. I'm showing you in this map a county by county account of poverty. And primarily most of the US African American population is centered here in the Southeast, which is also sort of a cluster of poverty. But recently in surveillance data, the disaggregation of affluence versus poor counties, as well as looking at race, indicates that Black patients, despite living in affluent counties, still have higher mortality than the poorest white counterparts, especially for prostate and breast cancer. And so while we know poverty does impact survival, race is still a stronger indication of survival. In the case of breast cancer, we know that Black women have a 40% higher mortality rate than white women, but that wasn't always the case. Historically, white women have had a higher incidence of breast cancer until recently. This is, because of improvement of screening and diagnostics. But prior to the mid-1980s, early 90s, it didn't matter if you were Black or white. You had the same opportunity to survive a breast cancer diagnosis. It wasn't until the actual initiation of clinical trials and then standard of care of targeted hormone therapies that we start to see this sharp decline in mortality only in white women, with Black women trailing by nearly 20 years. And so this gap still remains. Now, when we look at all of the factors that can account for racial disparities, interestingly, tumor characteristics outweighs, for instance, certain things that are socioeconomic based, such as, for instance, insurance and even comorbidities. Part of that tumor characterization includes hormone receptor status. This status of hormone receptor triple negative occurs in 67% of these are in African Americans. So African Americans are twice as likely to be diagnosed with triple negative breast cancer. It exists at the worst end of the prognosis spectrum. There are no targeted therapies. And in African Americans, it tends to be an earlier onset disease. Now, in a demonstration of why this is biologically distinct in African Americans, we know, for instance, that screen-detected cancers versus non-screen-detected cancers tend to have differences in survival rates because screen-detected means that the patient didn't even recognize there was a mass growing. This is something that was found by virtue of mammography or some other type of imaging, for instance. And so typically these are very early stage cancers and have a higher likelihood of being cured, as opposed to non-screen detected, meaning the patient detected an issue and therefore the tumor was large enough and staged later and therefore more difficult to treat. However, in African Americans, we look at this gap, it's almost twice, if not 3 times that of the mortality gap for white Americans. And also, interestingly, when we look at the screen detected, which again is this earlier stage cancer, we still see almost a 10 to 12% difference in survival, 5-year survival in African Americans. So when we think about what you actually need access to and what are the therapeutic agents currently in clinic for triple negative breast cancer, many clinical trials are currently underway with the intention of having a better treatment response. I'll point out a few of these, including, for instance, immunotherapies that are targeting specific immunosuppressive situations. So for instance, the PD1, PD-L1 interaction, PARP inhibitors, for instance, that augment, for instance, chemotherapies. And so we see a lot of these, for instance, in clinical trials. Interestingly, for triple negative breast cancer, first-line therapy is still anthracycline chemotherapy. We know that African Americans have a higher likelihood of having something called cardiotoxicity, leading to treatment-related heart disease. But interestingly, pharmacogenomics has told us decades ago that there are certain alleles or gene variants that predispose individuals for cardiotoxicity to some of these drugs. It's not necessarily something that's screened because it wasn't a cost-benefit analysis shown to not be of benefit. But when we look at who the people were in that study, we would see that most of them were European. I'll come back to that in a moment. But if we look at the African diaspora, nearly a third of the world's African population harbors these alleles that would indicate cardiotoxicity. And so just being aware of that could actually help to alter, for instance, treatment regimen that could completely change the outcome of a large portion of our patients. So this is one of the things we're currently studying. I'm just showing you, for instance, the racial breakdown of our ICS-BCS cohort for whom we have chemotherapy treatment information. And so we're doing a retrospective analysis to determine if, for instance, we can detect an association with cardiotoxicity with these alleles. Now, one of the reasons why this isn't necessarily currently in clinic is because our understanding of the genomic landscape is very skewed. I'm showing you here basically the ancestral breakdown of all of the current public data that's available. And by and large, the majority, vast majority, is of European origin, despite Europeans not being the majority across the world. This translates into clinic with this sort of distinction of variants of unknown significance being more prominently reported, for instance, in every other ancestry group. This simply means that there's a mutation in the gene that is cancer relevant, but it's a variant that's not known and therefore unactionable. So part of what we hope to do is put forth, a plan to utilize genomics to bridge some of that gap. And this is just a trajectory, for instance, of studies that have been published that look specifically at disparities using genetics. This is just one example of one of the things we use our International African Enriched Cohort for. And this is, of course, in partnership with all of our African partners. One of the things we identified, for instance, was the presence of an allele in a gene called ANCA1, where we see, for instance, this protective G version more prominent in European Americans with triple negative breast cancer, whereby African Americans had a higher likelihood of having this T allele, which is the risk allele. Now, interestingly, this gene actually changes the protein structure of the gene. This gene looks a lot like, on its protein structure, a lot like BRCA. And so we think that it has DNA repair capacity. And this could be linked to why the G version is protective while the T version is associated with higher risk. And specifically, we know that African Americans would be expressing the T version more likely. And so we think this is why, for instance, we see this even distinct and significant difference in survival of patients who have high expression of the gene. And so oncologic anthropology is sort of the approach that we take to utilize some of our findings, but also some of our discovery. And oncologic anthropology is really just a global approach where we're looking at, for instance, incidence and mortality rates across the world, but tracking, for instance, specifically the African diaspora. If we look at the global frequencies of triple negative breast cancer, interestingly, what we find is that in any nation where we're able to discern the component of the population with the highest amount of African ancestry, it is that part of the population that has the highest frequency of triple negative breast cancer. Dr. Newman had already studied, for instance, the incidence of West African triple negative compared to East African. But when we looked across all of the nations where we could discern triple negative status, we find that West Africa had the highest frequency. Since joining ICS-BCS, we even measured genetic ancestry in our multi-ethnic cohort, which would include European Americans, for instance. And we find that African ancestry, West African ancestry, is statistically associated with a higher likelihood of having triple negative versus other types of breast cancer. When we look specifically at our African Americans alone, who have a large range of admixture, ranging from less than 10% to more than 90% African ancestry, in just African Americans, we still see that retained association of triple negative specific risk. Now, we think that one reason we see this is because the African diaspora is unlike any other human population on the planet, where most times a founder population would simply be a singular movement or migration of a small group of individuals to a new region, and then hybrid populations thereafter. The African diaspora actually has something called continuous gene flow, where over hundreds of years, centuries, we have millions of Africans being displaced in every subsequent generation. And therefore, we have now this imprint of the African genome fully embedded across the Americas. And so everywhere you see a circle is somewhere we're currently engaged with collecting specimen or helping investigators with analyzing their cohort. One of the things we want to do with these biospecimens is look at whole genome sequencing. So we currently work with the New York Genome Center on a project called P1000. At phase 1, the only inclusion criteria was that none of the patients be of European descent. It was founded by Dr. Harold Varmus and Dr. Charles Sawyer. I serve as one of the co-PIs of the breast prostate group, where we focus on what we call the African diaspora in New York. But I've also infused some of our African samples as well, and the goal being to share this multi-omic data that we're generating, which includes whole genome sequencing of the tumor, as well as the germline and RNA sequencing of the tumor. And so I'm going to touch on just a few of the findings right now, one of which is identifying a variant of unknown significance in the BRCA gene, which happens to be in very high frequency in our Ghanaian and Ethiopian populations. We see that anyone who's carrying one of these alleles of this particular BRCA allele also have upregulation of the PARP1 gene. And remember, PARP1 is currently in clinical trial as a combinatorial therapy to assist with triple-negative breast cancer chemotherapy, but it's not necessarily indicated for individuals who would have this particular allele. And so this is by virtue of us finding this African-specific version of BRCA correlated with activation of the PARP1 pathway. We hope to introduce a clinical trial where patients who have this variant would also indicate to be candidates for PARP1 or PARP inhibitor therapy. Another aspect of the whole genome process is looking for what we call mutation signatures. Now, mutation signature is simply just the type of mutations that we find in the tumor, whether it's, for instance, A's changing to G's or dyads or triads. Each one of these signatures is particularly interesting because it's usually a function of the loss of some form of DNA repair. So signature 3, for instance, is associated with BRCA variants. And so we're looking at whether genetic ancestry is associated with any of these particular signatures by virtue of looking, for instance, for a driver of that particular signature. So far, we're starting to see some trends associated with African ancestry for a few of these signatures, but nothing of great significance yet. But, you know, hold on, we've only gotten like 30 done and we have 260 to go. So hopefully maybe this time next year, I'll be able to report back some strong findings, but we do see some promising results. Aside from the typical genomic structure that we typically see with whole exome sequencing data or chip data, where we look at copy number variation, amplifications and deletions in chromosomal regions, we're also able, using a new pipeline developed by my co-PI, Marcina Malinsky, something that allows us to see complex rearrangements within these copy number variations, which then basically allows us for the first time to look at the, you know, rearrangements that are occurring in these regions. And, you know, within these large regions are sometimes oncogenes. And so this is an example of one of those. I'm showing one patient here on chromosome 8. And this is a copy number amplification, but within it, there's a lot of, excuse me, a lot of rearrangement. It's in a region of a very high interest, AQ24, which was already associated with higher incidence or susceptibility to prostate cancer, specifically in African Americans in the US. But most cohort studies that looked at the variants in this region have very conflicting results. In some, the area was protective against prostate cancer, and others it was highly, you know, a high risk. This is unheard of odds ratios here. But I think what's happening is this structure that we see is actually also in the germline of our African patients. And so it's the proximity of these risk alleles, not just the presence of them, the proximity to the MYC oncogene that's probably driving the difference in whether or not the presence of the risk allele is a hazard for prostate cancer or not. And so quickly, I want to change gears and talk about gene expression just a bit. So one of the unique steps that we took for the first time in 2020 was, instead of using these boxes of African American versus white American, we actually measured genetic ancestry. And we used that genetic ancestry as a quantifiable continuous variable in our statistical models to identify association of gene expression associated with ancestry, as opposed to looking at self-reported race. And what we found was amazing. First of all, ancestry does correlate with race. So we should believe people when they tell us who they are. But I think that what we found and didn't expect was that a lot of these genes associated with ancestry were canonical cancer pathways, but they were activated instead of having loss of function. And so we went through all of these gene networks and identified genes that were over or upregulated, specifically in our African Americans, and identify, for instance, potential drug targets, drugs that are already targeting these genes, but may be utilized in other clinical settings. And so here is a blueprint of how we could augment, for instance, targeted therapies for people with triple negative breast cancer, because all of these patients were triple negative breast cancers, and we were looking directly in their tumors. And so we're currently using that Ghanaian organoid line to do CRISPR-Cas screening to find out whether or not these target genes we identified are actually responsive to drugs. So gefetamine was actually one of the genes in the previous, or drugs in the previous slide. It's not currently used in breast cancer, but it was one of our top hits in our drug screen. And of the 2 different Ghanaian organoid lines, one of them had a very high response rate, for instance, to the drug. Now, in our most recent publication that's currently in medRxiv, we went one step further. Instead of just using global genetic ancestry of East Asian, South Asian, European, Native American, and African, we actually measured then subcontinental ancestry. And what's interesting is that across this cohort, when you look at the African Americans, each one of these bars is a single individual. And what's really amazing to me is this like diversity that we see across this group of people. Every single person has multiple origins from Africa, multiple regions of origin of Africa, as opposed to, for instance, Ethiopians that have sort of a singular East African ancestry linked to Kenyan ancestry, and our Ghanaians having primarily West African ancestry. This group of individuals in the US is very distinct. And so it's no wonder that when we aggregate them together in one group and call them African descent, we really can't find what we're looking for. And so this just exemplifies the fact that we need to quantify ancestry across the entire genome of these individuals and then link their ancestry to genetic drivers. We utilized the same pipeline as before to identify genes that were African specific, for instance. And one of the things that we found was, again, this PARP1 gene activated, but also an immune suppressive marker, PCD1 or PD1. And we also saw this theme of immune response differences associated with African ancestry. And I should mention that in this cohort, it was primarily people of African descent. So we're talking about East and West Africans with African Americans primarily in this analysis. And so we're really focused on the influence of African, specifically West African ancestry on tumor biology. One of the more exciting findings was that we saw African ancestry associated with higher infiltration of tumor-associated leukocytes. We're using a deconvolution method called CyberSort to quantify the presence of specific immune cells. We validated that presence of immune cells using immunohistochemistry across our FFPE blocks, also seeing that Ghanaians and African Americans having higher infiltrates of certain immune cell types. We validated these markers using RNA-seq as well and verified that the presence of these markers was correlated with specific immune cells. And so this is painting a picture that African ancestry certainly is associated in real time with infiltration of specific immune cells. Even when we looked at sub-regional ancestry within our African Americans, because remember I mentioned they have ancestry from all of the regions, despite the region, we would always find a signature of immune response. And this brings me to my last segment, which is about the dark side of breast cancer. So there's a gene called DARK, there's a mutation called Duffy-Null. Individuals who carry this allele actually don't have the systemic function of DARK's ability to regulate systemic chemokines. And it was fixed in sub-Saharan Africa. It's an ancient mutation. It was fixed in sub-Saharan Africa because it also confers resistance to malaria. What we've shown is that the presence of the gene tracks, or the Duffy-Null allele tracks with that continuous gene flow, but it also tracks with the presence of triple-negative breast cancer globally. In the context of breast cancer, looking at the absence of the chemokine receptor on red blood cells, but knowing that the expression on endothelial cells is still present, we anticipated seeing something dynamic in the population. So we saw that expression of DARK was associated with more immune cells. Okay, it was associated with higher inflammation, and it's also associated with better overall survival in every type of breast cancer. Interestingly, though, at every level of DARK expression, we see that African Americans had a higher infiltration of immune cells. This corresponded with what I just showed you, which is that African ancestry is associated with higher infiltration. But it didn't really make sense, because if having higher infiltration of immune cells is associated with better overall survival, shown here in both early and late stage, and African Americans and Africans have a higher infiltration, then why don't we have a better overall survival? Well, it turns out that African Americans completely lose that survival benefit. So despite having high infiltration of immune cells, their immune cells don't behave the same. And this isn't a new concept. We know that immune cells actually behave differently depending on whether a patient is of African or European descent. In this infectious disease paper, they actually challenged immune cells from European versus African patients and saw completely different transcriptional profiles. And so now, coming back to the tumor, we're using something called imaging mass cytometry, which allows us to look at multiple targets on a single slide to now further characterize the dark immune tumor type. One of the things we're finding is that as we look across all of these different markers on a single slide, is from single cell data, that certain cell populations are more prevalent in either the dark high or the dark low population of cells in the tumor. So just quickly, this is my last data slide. In a dark high tumor environment, we see higher infiltration of T cells, for instance, compared to a dark low, which corresponds with what we saw on the RNA and in the IHC. However, I'm also showing you a heat map in this picture of PD-1, which is that gene that was activated in people of African descent. And lo and behold, what we find is that the majority of these high expressing PD-1 T cells in the dark high environment primarily come from our African and African American patients, compared to the dark high tumors from Europeans who have a lower expression of this PD-1 marker. And so this indicates to us that having Duffy null and systemic inflammation could potentially be driving the difference between having a better overall survival with tumor associated leukocyte infiltration. And when we looked at circulating markers, we certainly found one that was associated with ethnicity and race that deactivates cytotoxic T cells, is IL-1 beta. And it is one of, and we do believe that this is one of the factors that would be regulated by the set of chemokines of dark. And, you know, I just wanted to also point out that, you know, as my first slide about justice, you know, we should listen to where people live, their lived experiences, because this does translate to biology in the tumor. So we've been ignoring the self-reported race differentially expressed genes up until now. And what we found was that when we compared our African Americans to the African patients, we saw this strong set of genes associated with race or self-identity. And it's not because of European admixture, because Ethiopians have a tremendous amount of that. What we see is that it was associated with comorbidities, so diabetes, obesity, inflammation in adipose tissue, and cardiotoxicity. And all this really means is that the comorbidities that are the result of systemic racism also translate to the biology in the tumor. And so this is also important to understand, because this is the biology of the tumor that we're faced with when we're treating patients. And so this needs to also be incorporated in our understanding of precision medicine, right? That we would have a social construct understanding of our patients and who they are and what their lived experiences are, because it could ultimately affect the effectiveness of their treatment. And with that, I'll stop. Hopefully I'm not too far over. And if we have time, I'm happy to take questions. If not, thank you for your attention.
Thank you very much, Prof. Davies, for that exciting lecture that you've just given us. I think there's a lot to digest from it. And it was, it's a lot of data, and that should drive your precision oncology projects there. And definitely emphasized very well the importance of genetics in the study and the development of new approaches to cancer.
Thank you.
I just have, I'm sure there are lots of questions I can see here. I'm not sure online how many questions there are, but I've got just a few quick ones to ask also. You talked a lot about molecular signatures and risk alleles. I was just wondering, do these have to be dominant or recessive? Or also, and I was just wondering if you've taken the study further, maybe to model organisms, because I saw that in your profile, there are model organisms, but you didn't talk about model organisms at all, to maybe test the causal relationship between these lesions in cancer, and I'm sure there'll be a lot more questions asked after me. I've just got
right. So I'll answer your first question about dominance versus recessivity. I think that it really depends on the allele. So for instance, the one that I demonstrated with ANCL1, it appears to be a dominant allele, but most loss of function mutations tend to have some level of impact because you're losing you're losing part of the function, right? And so losing part of the function can affect, for instance, penetrance. But the BRCA gene is certainly an example of it being recessive, where even having one good copy of the gene can lower your risk of having breast cancer. I think that we're going to find that other mutations in kinase genes, for instance, there's one that was in one of the slides called NEC2. I think that's going to be a dominant allele. Our P53 gain of function is going to be a dominant allele because it basically excites the gene, overactivates it. And we see, like, yes, we do have model organisms in both mice, for instance, for the P53, but we're also using ex vivo models, those organoid models, where we're using CRISPR-Cas9 to design or redesign the particular mutations in the Petri dish, to see whether or not we can recapitulate what's happening in the tumor in terms of genomic landscapes. I didn't have time to talk about it all, but yeah, we don't have funding yet for some of these, so it's sort of in pilot phase currently. But yeah, full intention of modeling all of the things that we find.
Melissa, fantastic talk. This is David Bates from the University of Nottingham. Hi. One of the things that struck me was you've got RNA-seq data there as well. Are you able to look at splicing and to see whether there are significant changes in alternative splicing that are associated with ancestry? And the other question I've got is, you've focused predominantly on our African ancestry. Have you got any information on Australian indigenous ancestry as well?
Wow, great question. So we do some transcriptomic analysis where we're looking at splice variants of certain genes that we're interested in, but we haven't done the analysis systematically for splice variants. But I will add that, part of that complex rearrangement, assay that will come from the whole genome data, we plan on coupling the RNA-seq data with the whole genome data to really look at whether or not it's a rearrangement of the genome versus utilization of, splicing mechanisms. So it's in the plan for forthcoming work, but we haven't necessarily looked at that yet. And I'm sorry, repeat your last question. What was the last question?
I was just wondering whether you'd looked at any Australian indigenous ancestries as well.
Right. So no, I don't necessarily have access to that, but interestingly, there's a woman who was recently at Weill Cornell who's looking at prostate cancer in Aboriginal and maybe Melanesian populations, if I recall. But I think it's a fascinating question because it really gets at African origins, sort of the ancientness of some of the drivers. I'm very interested to look at it to see. But no, we haven't. Thank you for your question.
Thank you. My name is Tabe Matsawatlela from the University of Limpopo here in South Africa. Thank you for the wonderful talk looking at genetic variations in various ethnic groups. I'm just wondering, looking at all these data sets, were there any correlations seen between the various ethnic groups and how they respond to drug treatments? One of the things we look at is response to drug variations or drug derivatives. And I'm just wondering if there were any significant response to drug treatments from these various ethnic groups. Thank you.
Prof, looks like you're muted.
No, yeah. I'm unmuted. You can't hear me?
We can hear you now.
Okay, sorry. I was asking for clarification on your question. You mean within Africa or just comparing African Americans and European Americans?
Just all over the ethnic groups you've studied.
Gotcha. Yeah, so I think that what we do see, for instance, is, yes, there definitely is correlated with race, what appears to be effectiveness of treatment, right? But at its core, when you dig more deeply into whether or not patients completed the full regimen, or and why wouldn't they complete the full regimen? Some of that has to do with tolerance to therapy, not necessarily the effectiveness of the drug. And then some of that has to do with socioeconomic status and whether or not patients are able to complete their therapies, if not for cardiotoxicity, financial toxicity. We also see, for instance, in Africa, sometimes Dr. Newman talks about this, where a patient was, under a chemotherapy regimen, but when she does her operation, sees no sign at all of what she would anticipate being sort of a shrunken tumor if the patient really had been on chemo. So, what is that? We're not sure. We don't necessarily have a biomarker to detect the potency of some of the chemotherapies that are provided, but we also don't know if it's just because of what you just mentioned, that it's just not as effective, given the pharmacogenetic profile of Africans, whether or not there's actually an interaction there. So I think, the field is wide open. I think we need to investigate the very question that you're asking, because we don't know whether or not what we have in our arsenal is as therapeutic, in certain populations as it is in others for various reasons. And I think, the problem is so complex, right? That accessibility is an issue, but then once everyone has access, is it really effective is the next question. I'm working on that second question. And I think that, we do need to think more carefully about whether a generalized systemic therapy is the way to go, specifically with triple negative breast cancer, because of the heterogeneity of triple negative breast cancer, but then also because of the heterogeneity of the patient population. So it's a very important question. And we only have clues right now, nothing, substantial that I could change the field. But, I think we have enough that warrants further investigation.
Thank you very much.
Thank you.
Prof. Davis, there are no more questions from the floor. I should thank you very much for this wonderful lecture, and wish you a great day moving on. It's early in the morning. I suppose you still have a long one in front of you. But we thank you very much for coming. Thank you. Thank you very much.
Thank you, everyone.
Colleagues, so now I'm going to hand over to our next chairs. And that will be Prof. Tabe Matsabatlela and Prof. Doreen Ramakhuamasire. Where is she? Oh, this is virtual.
I'm on your screen. Good afternoon, everyone. My name is Doreen Masira. I don't know if you can see me on the screen. I'm a professor of obstetrics and gynecology and the Deputy Dean for Research and Graduate Studies at the Faculty of Medicine at the University of Botswana. It's such a great pleasure to be here. Virtually, I wish I was there, and really up to now, what a treat it's been. Congratulations, Prof. Zodwa and your team. You really are making us proud. I don't know where my co-chair is, but looking at the time, I'm going to take this opportunity to quickly go in and introduce our next speaker, who is Professor Mutadi, who's going to be talking to us about the effects of the natural HPV vaccination program in South Africa, focusing on the young male vaccination. And Prof. Mutadi, I'm just going to do a very brief bio, because I know you all have it, just to save time. He's a cancer researcher for more than 17 years. A major area of specialization is molecular oncology. He does actually serve in many committees, and one of the key ones is that he's an advisor for the Department of Monitoring and Evaluation of Health, and he serves in the American Society for Cancer Research International Committee. Just to remind Prof. Mutadi that he has 10 minutes for the presentation and 5 minutes, and if you run out of time, then there won't be any time for questions. So thank you very much, and over to you.
Okay, thank you. Thank you very much, colleagues and distinguished guests. Firstly, I would like to thank Professor Zora Dlamini, who I come far with her. I'm one of the products that she produced as a PhD student, and we're still marching all the way to through this research. And one of the most important thing about this PACRI is that I really appreciate that you are bringing basic sciences with clinicians together, which is something that has been lacking in South Africa. As you remember, when you go through ARC conferences, you will find that it's very difficult to interact with other physicians from South Africa. So my topic today is the effect of HPV vaccination program in preventing male cancers, a case for young male vaccination. And I think Prof. Dave spoke about vaccination in UK yesterday, and I was like, he's basically touching on some of the things that I really look forward to doing in South Africa. But the difference between South Africa and UK is that with UK, as he has said yesterday, is that you have the vaccination and the safe sex. So whereas it's something that is missing in Africa, so the safe sex and HIV that is continuously defying the medical science, particularly in South Africa, continues to be a problem. But what I would say is that cancer is one of those diseases that you're related to a bully, either it's adversity or high school or primary, that will tell you that you found me here, you leave me here. Because whether COVID comes or any other disease comes, cancer will remain with us for many years to come. So one of the most important virus in this case is human papilloma virus. And then we know that the most variant that actually causes that is that causes cancer is type 16 and type 18. And then they contribute mainly to about 60% of the penile cancers in the world. So what we are actually trying to look at is that this virus, together with HIV in most cases, is that they increase the level of E6 and E7. And then we know that once the level of E6 and E7 are increased, that actually interferes with the p53 activation. This structure was drawn by Dr. Muela, who is also a researcher here at UP. So, and then once we have inactivated p53, obviously we'll get the development of cancer, and then therefore we are unable to combat that particular cancer. So HPV and HIV, which is the most common viruses that exist in South Africa, they actually inactivate E6 and E7, and therefore resulting in p53 inactivation, and therefore resulting in cancer. So in our study, basically what we are trying to do is that we are actually looking at those females that are vaccinated, and then from those females that are vaccinated, we are trying to get the antibodies from them and isolate those antibodies and then purify them, and then from there try to reintroduce them in cancer cells with the hope that these antibodies now, they will then trigger the immune system in cancer cells. So we know that cancer cells, most of the times, they have within their surfaces, they will have MHC class 1, and then those MHC class 1, they will present the antigen that is associated with that particular cancer. So with HPV vaccine, we believe that this HPV vaccine will be able to produce certain antibodies, and then these antibodies, then when we reintroduce into a cancer, will therefore bind on the surface of these cells, and then therefore in so doing, they will recruit the T cells to come and attack that cells. I know that yesterday we had that this continuous mutation, and then this mutation then affects the MHC class 1, which is actually another something that made me think, where are we going there? But again, if you look at this one, what we did now is this just a preliminary study, and then it's very difficult to get people that will actually volunteer to participate in the research because of the stigma behind it. This project basically is running between us and Ghana through Prof. Asa at University of Ghana. So, but this one now, we actually run it through the University of the Klerksdorp municipality. We had an agreement with the Department of Health in that province. So we have been trying to collect sample as much sample as we can, but it's very difficult with the stigma that is associated with HIV and the HIV and HPV. So in this study, basically we just collected blood sample and then also questionnaire to about, we had 56 patients coming to the clinic. From that 56 patients, some of them we were excluded. In this case, we were excluded based on whether they refused to give us blood, whether they refused to actually give consent, or any other reasons that they had given to us, so that makes them to be excluded from the study. So that is basically what we did. So, but from there, we end up with only about 26 of the samples, both male and female, and then therefore we actually extracted RNA and using the triazole, and then we had also the controls that we are associated with. So from the study, from the questionnaire, what we did is that to just analyze quickly who is who in the study, and then what exactly their belief in terms of whether they know, they're aware of the vaccine or any other information that we looked for. So one of the information that we looked for, we were looking at their sexual orientation, whether they are same sex or not. And then they were about 10 of them that actually volunteered. And then the females, of course, also they were there. And then we looked at the age groups again. Most of them, they were younger, about 18 to 25, and also we had the older ones, because mostly the older ones that are refusing to actually participate in the study. So in terms of HPV positive, this is basically, we find that it was not that much high in terms of the sample that we have. Of course, the sample is very low, but then it was not that much high. And then the pap smear, in terms of pap smear, there were none of those samples that we actually detected any pap smear. So then because of we wanted to check, this is basically what the result shows, that the HPV, we ran the gel, and then PCR then ran the gel to make sure that to try to identify, because with males, we had to test with the PCR to check if they had it or not. So this is the results of samples that we ran from the 19 that we had. We could see that where there are bands is the only 6 samples that we actually could identify with the HPV present in that samples. And then the HPV 2018 also, if you see, there are very fine bands there, and this also shows that the samples that were actually showing signs of positivity in terms of HPV. So in essence, is that, so in essence is that from this study, basically what we are doing now, what we did is that we also went and bought the HPV antigen from GeneTech, and then from the GeneTech antigen, this antigen was actually attached with a bit. So then we had run the column, and then from there we are trying to purify this particular protein through the column. So what we do is that we run the column, and then pour the serum within the column and then therefore be able to separate or separate the antibody that we are looking for from the vaccine. So if those that are actually vaccinated, we believe that they will have had this antibody that is synthesized within them, and then therefore the antibody will be able to bind to the antigen, and therefore will purify that, and then from there, as I said, will transfer that antigen to cells, and therefore monitor if these cells actually contribute towards reducing the cancer. Basically, this study is more going to work for any cancer that is will resurface after maybe resectioning, and later on it comes back after the treatment. So that's basically the preliminary study that we had undertaken, and we hope that will liaise with PACRI for actually assisting us in this research. And thank you.
Thank you very much, Prof. Motadi. I think you do actually have some time for some questions. I don't know if there are any questions in the chat. I don't have access to that, or questions from the audience. I can't see the audience, so somebody will have to point those out. I don't know where my co-chair is. I'm assuming that my co-chair is live.
I am identifying the questions for you. That is me. I'm checking if we have. I'm checking if you have questions. We have one.
Yes, they are supposed to be neutralizing.
Can Prof. Mutadi? Maybe you just use the mic to...
So you're saying if they will neutralizing transform cells? Yes, that's basically where the problem is, because if you look at some of the data, is that because the ones that we use, the cell lines that transform cells, basically it's more unlikely that they will work against the transformed cells. So, but then we actually also working with the animal care at Northwest University that actually will be able to help us in that regard. So basically with the cell lines, I don't think it will work because the cell lines are basically transformed cells. So they will not actually express such markers in the surface of the cell.
I think I'm checking if we have a second question. Don't worry, Dolina, I'm your eyes here. Looks like we do not have a second question. Right. Looks like we have exhausted all the questions. Thank you, Prof. Mutadi. And I think we can move on to the second speaker. My name is Tabe Matsebatela. I'm from the University of Limpopo, Department of Biochemistry, Microbiology and Biotechnology. I stand in for our director. Oh, yes. There is an announcement. If you have seen a mobile phone, please take it to the front desk. There seems to be a loss of a mobile phone. If you can kindly, if you have seen it, hand it over to the front desk. Thank you. Our next speaker, I was still saying I'm speaking on behalf, standing in for Prof. Mampuru, who's our school director in the School of Molecular and Life Sciences at the University of Limpopo. And he is very much excited about being part of PACRI. We do have a multifaceted cancer research group. And one of the speakers who's going to speak next is from our research team, providing the molecular aspects of different types of cancers that we work in and nanomedicines. And we also have groups that work on medicinal plants and synthetic molecules, and also some groups on diabetes and relations between inflammation and cancer. And Prof. Mampuru would like us to send his regards to you and your team, Prof. Zodo Dlamini, and wishes that we have a fruitful collaboration between us and the team at the University of Limpopo. Our speaker is going to be Professor Zukile Mbita. He is a colleague of mine. He obtained his PhD from the University of the Witwatersrand under Prof. Zodo Dlamini. Thank you, Prof, for giving us one of your products. And he also served as a research coordinator at the College of Agriculture and Environmental Sciences at the University of South Africa. He is passionately involved in cancer research, focusing on molecular aspects of retinoblastoma binding protein 6, and he studies processes in carcinogenesis and mainly focusing on nanomedicine and medicinal plants as his focus of research. And proteomics and functional genomics are part of the tools that he uses in his studies. Shall we welcome Professor Zukile Mbita to come and give us his talk, which focuses on the use of medicinal plants and nanomedicine on anti-cancer molecular mechanisms. Professor Mbita.
Greetings, ladies and gentlemen. I want to take this opportunity to acknowledge the hosts, the University of Pretoria, our founding director, Professor Zodo Dlamini. We want to acknowledge the work that she has done. I want to congratulate her for all the achievements that she has done, she has achieved, but most notably the establishment of this world-class PACRI Institute. I can't see my my presentation. I'm going to talk about the role medicinal plants have in combating cancer. I'm not sure if maybe I can use my computer because now it looks like it has not been loaded. Is that possible? Okay. Okay, while we wait to connect my slides, can somebody assist me? Send them. I'll just talk while I'm waiting for them to connect. The work that we are doing is looking at different plants. But I think yesterday we had Professor Bates talking about the different, actually the statistics that of cancer across the world. What I wanted to highlight was the fact that Africa is actually, we're starting to get a lot of cases that are cancer related. So I wanted to show a map where we saw that Africa is actually, especially South Africa, has got, is the second, has got cancer as the second leading cause of death. So now it is really hard for me to really continue without the slides, but I will just maybe give them a moment or so.
Maybe in the meantime, you can tell us about your experiences with Professor Dlamini.
Okay, I think I met Prof. Dlamini. She was still a postdoc then at the University of the Western Cape, under the leadership of Professor Disparities. Okay, thank you. I think after I finished my honors, I wanted to go and look for a job, but unfortunately, she convinced me to actually study further, and there was an opportunity to actually join University of Witwatersrand as a master's student, and ever since then, we've been working together. I think when she was still my supervisor, she always talked about establishing a cancer institute. So I think this is a dream come true for her. I think I'm really happy for her. Okay, thank you very much. As I said, my talk is going to be on the work that we're currently doing, which is on using medicinal plants to try and find ways of eliminating cancer. Okay. Okay, I'll try to not waste any more of your time, because I think the challenges that we have had in terms of connectivity. I want to actually talk about cancer as a case across the globe. I wanted to show and highlight the worldwide trends where people use medicinal plants, and then I will look at the research that we are doing, looking at molecular mechanisms that are induced by these medicinal plants. And then obviously I'll give some brief findings and future perspectives of what we are planning to do. As Prof. Bay said yesterday, we have South Africa having the third cancer as the third leading cause of death. So I'm not going to spend more time on that, because I think the statistics that he gave yesterday were quite fulfilling, because we could see that there is a need to really try and combat this deadly disease. Okay, why are we having these cancer cases going up? I think we have cancer risks, risk factors that are there. We can talk of genetic changes, where we look at mutations that can either be inherited, or we have mutations that are caused by what we consume or the environment. We have biological factors, which include age, the lifestyle, the gender, because we know that some cancer cases are due to, they affect certain types of or different genders. And then we have environmental factors, where chemicals, exposure to chemicals, like in the case of asbestos, radiation, can also cause cancer. Obviously, there are those that are still smoking, even though it is well documented that smoking can cause cancer. And there are other cases, factors, like poverty, where we know that what you consume can actually affect how your body functions. We have diseases that are linked to predisposing to cancer. For instance, HIV/AIDS, we know that we have cancers that are related to HIV. That can actually be linked to infections. So I don't want to waste more time on that. Okay, the carcinogenesis process is actually quite a complicated talk that we can talk the whole day trying to find what actually causes cancer. But a paper by Herman and Weinberg in 2000 actually highlighted the different hallmarks of cancer, or the things that the characteristics of cancer cells. So we actually looking at trying to combat this and fight cancer by targeting some of these processes, which include resistance to cell death, sustained proliferative potential. We also looking at evading immune system. So I think so far we have had so many papers that are looking at that have been published looking at medicinal plants and the way that they are used to combat cancer. So as from the 2000s, I wish I had, do we have a point? Okay. As from the 2000s, I think the numbers have been increasing exponentially. But I think around, the last decade, now the numbers are starting to go down, because I think the journals are starting to look for more information than just to look at the plants that have got activity and what else, what can be done after that. If you say there is this particular plant has got activity or anti-cancer activity or any other activity that is there, or bactericidal properties, but we need to now understand the mechanisms that these particular plants induce. So I think these are the fields that have been dominating in medicinal plants. Obviously, you can see biochemists up there, but pharmacology discipline has been publishing more. One of the fields that I'm more interested in, the material science. Now you can see now the numbers are starting to also go up, but they are not that much. But I think the field of biochemistry is involved in medicinal plant research. So now I want to share with you the work that we are actually involved in. We have got 3 plants that we have been studying in recent time. The Commelina bengalensis, Trimia calcarata, as well as your Monsonia buchiana. The Commelina bengalensis is actually a weed that you will find in many gardens, but it has been documented that it's got lots of biological activities. One of them is anti-cancer activity. We have demonstrated that it has got anti-cancer activities against breast cancer cells. We have also used it to synthesize nanoparticles using the green synthesis method. We have also used this plant. It has also demonstrated its regulatory, it contains biomolecules that can regulate splicing. The Trimia calcarata has also demonstrated anti-cancer activities against colorectal cancers or cancer cells. It has also shown effects on the splicing of tumor suppressor gene, which is your P53, and some of the STATs transcription factors. The Monsonia buchiana unfortunately didn't show any anti-cancer activity, but it was also successfully used to synthesized nanoparticles that had bactericidal effect with no anti-cancer activities as well. Now, this is just to show you some of the work that we have done. The Commelina bengalensis extracts, which were fractionated with using dichloromethane as well as hexane. The dichloromethane fraction showed activity against MCF7 cells, while the hexane showed no activity at all. So we still want to know which of the compounds within that were found within the within the dichloromethane fraction. So on the right, on my right, you'll see that one of the mechanisms that were affected by the dichloromethane fraction was the PI3K signaling pathway, which is highly activated in breast cancer cells, but this Commelina bengalensis fraction showed an activity where it actually inactivated it significantly. If I move on to the nanoparticles that were derived from this Commelina bengalensis, we tested their effect on lung cancer cells. It showed activity where it resulted in reduction in the proliferation of the A549 cells, where we used the Ki67 marker to demonstrate that it's anti-cancer activity. Obviously, the last plant that we are recently trying to understand its effect on cancer cells, we actually tested the Drimia calcarata water as well as your methanol extracts. We showed that it reduced the cell viability when we used FACS to determine the cytotoxic effect of these two extracts. What was interesting was that the two extracts had a varying effect on the P53 splice variants. Now you will ask me, okay, which or what are these splice variants? We are still trying to figure out which of these are novel, because we have been looking at the literature, looking to see which of these are they mutated, or is those mutations, or are they really splice variants? But it was consistent. It was consistent across the different cell lines, where we demonstrated that in some of the cell lines, the variant 1 would be downregulated by either the water extract or the methanol extract. Okay, on the far right, you'll see that these were the loading control or GAPDH could actually show that these are real differential expression of these particular variants. Okay, I think the Buchiana, the Monsonia buchiana, we showed that it has got, we could actually use it for synthesis of nanoparticles. So in 2018, we published a paper in collaboration with my wife, where we showed that it could actually we could successfully use it to synthesize nanoparticles that had antibacterial activities. Okay, the take-home message is that there's still a lot of work ahead when we look at the role these medicinal plants can be used in anti-cancer activities. Obviously, there will be a hindrance that is affecting everybody, funding, and obviously the priority is to get infrastructure. And I'm happy that there is an establishment of an institute of this magnitude, where I think the collaborations with Professor Dlamini will come handy. I'd like to thank my family for their support and understanding throughout the projects and the sacrifices. I want to thank National Research Foundation for funding some of the work. I want to thank the University of Limpopo for the employment, obviously the Department of Biochemistry, Microbiology, and Biotechnology. Obviously, this work, we had challenges with our freezer, so we kept on asking for cell lines all over the world. So I think I want to acknowledge their assistance every time we ran out of these challenges. Thank you very much.
The Corey cycle was discovered by Corey and Corey husband and wife. I do not wish to go on and talk about him and wife collaborations on the studies, but we can take a few questions, maybe one or two. Yes, please.
So I just wanted to find out, I mean, I saw that your, P53 has got multiple splice variants. I think there are more than 6 splice variants. So the one that you've chosen to PCR here, what basis was it? And also the MDA231 cells normally have a dysfunctional to a P53. But when I looked at your program, there was, your profile there on your graphs, there was no difference really with the other cell lines. Was that a correct observation?
Thank you, Prof. Ndasa. I think what we are trying to establish now, because in some of the cell lines, they've got a mutant P53. So we want to see the region that we amplified, if it's also involved in those, what to call it, it's also part of the mutant P53. In terms of the profiles, I think the plant had varying effects. I don't know if they could actually show the slides, but I think what we can say now is that the MTA or even other cell lines, there was a difference between the effect of your water extract and your methanol extract. But in some cell lines, they didn't have any effect at all. But what is missing there is where we were looking at the untreated cells, because there is just a ladder showing the effects on the treated cells. I think it would have been nicer to demonstrate that in the untreated cells, there were no bands at all.
I think due to time, you can take maybe one last final question. I think we all agree that cancer is originating from genes, and therefore studying molecular genetics and carcinogenesis and the molecular patterns, functional genomics that we've seen in this session and the previous session, and tracing the origins of gene expressions and cancer will then lead us to drug targets and drug treatments. We have one last question, and we will have Dolene. You can have one last say after the response to the question, and we can close the session.
Thank you for the talk, Prof. What I wanted to ask is, with the plants that you are screening, what motivated you to want to test them in cancer? Do they have any previous medicinal purposes? You might have mentioned it and I might have missed it. And another question that I'd like to ask is, with these plants that we are screening against cancer, do you always expect that they will induce apoptosis, or is there any characteristic that they come with that make you want to test whether or not they will induce apoptosis?
Okay, thank you. I think what happened is that when I joined the University of Limpopo, 2015, I had a student who was interested in doing medicinal plant work. And from then, we decided, okay, we will screen different plants for anti-cancer activity. Obviously, if we get a plant, we still need to do what we call literature search to see if there is any work that has been done on them. So in this case, for Commelina bengalensis, I think there's been demonstration of its what we call it potential as an anti-cancer medicinal plant, but they had not tested it against the breast cancer cells. So we wanted to see if it has got that activity there. In terms of, we always expect to see anti-cancer activity. Not really. Sometimes we try to see whether the plant has got that activity, or because the traditional healers, they tend to use these plants to treat different variety of diseases. So that is a motivation of actually using them, of investigating their activities, especially anti-cancer. In terms of, we always expect them to have anti-cancer activity. I think the first thing we normally do is to characterize their phytochemical constituencies. So if now, for instance, the second one, the Dreamia calcarata, had been studied somewhere in KZN, there was only one publication when we started with it. They had isolated one compound, but the solvents that they used were different. We're always interested in seeing whether we can use the water extracts and test their activity, because my interest is to emulate what traditional healers use, because they do not have the solvents. For instance, the Dreamia calcarata, when they isolated one active compound, they used dichloromethane, which I don't think it's there in our communities. So we always chose to use water as our standard extraction solvent. I'm not sure if there's another question that I missed. Okay.
Thank you, Prof. Mbita, for the wonderful talk and taking the questions, ladies and gentlemen. And I'll invite over Professor Mondem Twasa to come back and take over the next session. Thank you.
Thank you very much, Prof. Matsa. And now we are going to give you some presents. Prof. Dlamini, would you please come forward? This is also for Prof. Doreen. Is she gone? Still there? Are you still there?
Yes, Prof? I need my present.
Where are you, by the way?
I'm in Botswana. I'm in Gaborone. Yes.
Yeah, that's too far.
I'll come and get my present. Thank you.
Please take an Uber to Johannesburg.
I will do so.
Do you want to? Please come forward, Prof. Is that paparazzi? Colleagues, we are approaching the final lap of this session, and this is going to be what I call Express Hour, because we're going to have a series of presentations, 10 posters that will be presented here. I think they're going to be projected on the screen. Each is going to take 5 minutes, and we shall not allow any questions. maybe towards the end, if there's some time, we can ask questions. So if you have any questions, please jot them down, and then at the end we shall accept questions. The first one will be by Dr. Mariel Oyomno. She's from the University of Pretoria Department of Surgery, and she will present a poster on molecular profiling of colorectal cancer in South African patients, preliminary findings and recommendations from the 5-year retrospective review.
Good afternoon, ladies and gentlemen. Thank you for this opportunity to present. I'm currently a colorectal surgeon in the Department of Surgery in Steve Biko Academic Hospital. In the past year, since I started working there since 2017, there's something I noticed. I was seeing younger patients with colorectal cancer. They were Black patients, they had worse tumor biology, and they're getting worse outcomes, in keeping with what we are seeing that was discussed yesterday. And the question became, is this something that I'm actually seeing, or am I just empathizing with the patient? We began the University of Pretoria colorectal surgery database in 2018, and these are some of the preliminary results that we're presenting, which have validated what we are seeing, that our patients are much younger. And we extended this to become part of a PhD study where we're looking at what is the cause of this young age of patients, what is causing this worse tumor biology in our patients. And we think it's at a molecular level, and that's what we're going to be doing next. So we have created a biobank and have been collecting tissues, fresh tissue samples, blood samples from our patients, and we're soon going to be running that. What I'm going to present today is just the preliminary work. So we know that globally, the incidence of colorectal cancer is increasing. While the incidence is increasing in Africa and the mortality is increasing in Africa, in the rest of the world, the mortality is decreasing because they've got better cure, better surgery that is being offered to the patients, and their screening programs. Currently, we have no colorectal cancer screening program in South Africa. Additionally, the international literature says that if you're going to screen for colorectal cancer, you should begin at the age of 55. It's only in April 2021 that the European guidelines then say that you should screen from the age of 50 to 75, and in America, they have now dropped it to 45 years with the acknowledgement that ethnicity does play a role, and that means in our Black patients, cancer is occurring earlier. So if I'm sitting and waiting for my patients to screen them at the age of 55 years or 50 years, I have 30-year-old patients, 20-year-old patients, and we're missing those patients. So what we've done is that in the data that we've collected, we were able to see that our mean age of our patients was actually about 54 years, and majority of our patients are presenting with advanced disease, stage 3 disease and stage 4 metastatic colorectal cancer. We've also been able to look at what features of bad tumor biology these patients have, lymphovascular infiltration, whether they're poorly differentiated cancers. And what we are seeing is most of our patients are moderately differentiated cancers. About 37% have got lymphovascular infiltration. And basically, what we are looking at, what is causing this? We tend to think that in younger patients, colorectal cancer is associated with being inherited cancer. But most of our patients are not the Lynch syndrome that we'd expect, with the MSI and the mismatch repair genes, microsatellite instability that we expect to see. And so hopefully as we proceed to the next phase of this study, where we're going to be doing molecular profiling of these tumors, doing next generation sequencing, TSO 500, looking at the splicing variants, looking at the mutations that we're seeing, we'll be able to answer that question and come back to it. So just highlighting from the slide, in the areas in terms of, just the age of the patients, what struck me was that while you've got patients who are in the 60 to 70 age group, look at how many patients we have from 20 to 50 to 60. That's a big group of patients. That's the economic workforce of our country, the future parents. If you look at the stage where the patients, the differentiation, most are moderately differentiated, like I mentioned, but most of our patients are presenting late. So this led me to think that the recommendations and the things we're seeing, we definitely need to start talking about a screening program in South Africa for colorectal cancer. If we're going to start one, with the knowledge that the adenoma to carcinoma sequence takes about 8 years, we can't be trying to start our screening program at the age of 50. We need to be looking at what age are our patients. If it's about 54 years, go about 10 years earlier. We're talking about 45, 40 years, in line with what they're seeing in America. Second thing is that other than the screening program, the quality of surgery that we're offering our patients, when you look at the margins of excision and just taking into consideration factors in terms of how long it gets patients to come from the rural areas to come in, we may need to improve the operations. But most of all, we need to study these cancers at a molecular level to see what's causing this in our young patients and how can we create new biomarkers. Thank you.
Thank you very much for a really lovely talk. I wish I could go further, give you more time, but we don't have. The next poster will be from Miss Angela, is it Bona or Bona, from the University of Pretoria, Division of Genetics, as Department of Biochemistry, Genetics, and Microbiology. And she will talk on the anti-cancer screening of Cameroonian plant-derived compounds in cervical cancers in vitro. Is it Bona or Bona? Bona.
Hello, can everyone hear me? Okay, I'd first like to thank everyone. Thank you, Prof. Dlamini, for hosting this event and providing me the opportunity to present here. My name is Angela, and I'm studying my master's degree under the supervision of Dr. Moela, and my co-supervisor is Dr. October. Cervical cancer is a public health burden among women in Southern Africa. Current treatments, such as platinum-based chemotherapeutics and radiotherapy, collaterally harm benign tissue in patients and are very expensive to produce. To address this, we performed anti-cancer screening of 10 plant-based compounds and assessed their cancer selectivities against a non-cancer cell line. 2 compounds that are newly extracted showed anti-cancer activity, and especially in combination. This proposes plants as an additional treatment of anti-cancer. Let me rephrase that, sorry. This proposes plants as an additional source of anti-cancer leads. Compounds were isolated by our PhD collaborator in the Cameroon, with whom Dr. October is affiliated. Compounds, 2 compounds of interest, namely CAE21 and EGF25, which will be referred to as C21 and E25 from now on. These compounds were extracted specifically from C. aurore and E. gracilis plants. Compounds were dissolved in DMSO and subject to cytotoxicity and selectivity assessments in HeLa and Vera cells, using MTT and real-time cell analysis. The IC50 and selectivity indices were used as cytotoxicity and cancer selectivity metrics. The IC50 is the compound concentration that reduces cell viability by 50%, and the selectivity index is a ratio of the IC50 in non-cancer cells to IC50 in cancer cells. Downstream studies involved in annexin V and propidium iodide stains in HeLa cells to quantify apoptotic and necrotic cells using flow cytometry. Compounds with IC50 values below 50 micromolar and compounds with selectivity indices above and equal to 2 were considered sufficient and chosen for combination treatments in downstream cytotoxicity analyses. C21 and E25 were chosen as their IC50 values of 40 and 45 micromolar, to be exact, were below 50, as opposed to selection based on their selectivities, as their selectivity indices were below 1. This could be explained as each compound affects molecules that are not species or cancer specific. C21 and E25 co-treatments resulted in significantly increased cytotoxicities at half and full fractions of their respective IC50 values. This was confirmed by real-time cell analysis every 15 minutes for 48-hour treatments. However, the DMSO solvents for E25 alone and combined with C21 also showed cytotoxicity at 2.1 and 3.5%. C21 and E25 exerted their cytotoxic effects mainly via apoptosis, with no necrosis compared to C21 and E25 individually after 24 hours. This was consistent with results found in literature that states that flavonoids, such as E25, induce apoptosis via oxidative stress involving mobilization of copper ions. And terpenoids, with which C21 resembled, induces apoptosis via interaction of the BCL2 family proteins. Plant-derived compounds are diverse and thus synergistic as their combined medicinal properties culminate, possibly explaining how C21 and E25 had an additive apoptotic response. However, this needs to be further explored with consideration of other metabolic pathways. Also, cells were sensitive to DMSO, and compounds were used sparingly as they were circumstantially limited. Therefore, this warrants further repetitive investigation using alternative drug vehicles as well as additional cancer biological models. Thank you.
Thank you very much, Ms. Werner. That's very nice. The third one. Sure. Computer is playing games with me. Third one now is by Ms. Hasheni Mehta from the University of Pretoria, Division of Genetics, Department of Biochemistry, Genetics and Microbiology, and she will speak on probing the effects of retinoblastoma binding protein 6 knockdown on the sensitivity of cisplatin in cervical cancer cells.
Thank you. Good afternoon, everyone. Today I'll be telling you a little bit about my master's project titled Probing the Effects of Retinoblastoma Binding Protein 6 Knockdown on the Sensitivity of Cisplatin in Cervical Cancer Cells. Now, cisplatin is an FDA-approved drug that is widely used to treat many forms of cancer at advanced stages. However, the problem arises when individuals develop resistance towards this drug, either through BCL2 upregulation and P53 repression. The retinoblastoma binding protein 6 regulates P53 and BCL2, and it is associated with apoptosis and cell proliferation, making it a promising cancer biomarker. Therefore, in this study, we aim to investigate the effects of silencing RBBP6 on the sensitivity of HPV-positive cervical cancer cells towards cisplatin via the BCL2 and P53-mediated pathways. To do this, HeLa and Cascade cervical cancer cells were cultured and transfected with RBBP6-specific siRNA for 24 hours. Following this, the transfected cells were treated with cisplatin for an additional 24 and 48 hours. And finally, the downstream effects on gene expression, apoptosis, and cell proliferation were analyzed. We noticed that the RBBP6 gene was successfully knocked down in HeLa and Cascade cells, resulting in significant downregulation of BCL2, which is a gene that is said to be promoted by, a gene whose transcription is said to be promoted by RBBP6. This was coupled with a small percentage of apoptosis induction in the presence of diminished RBBP6 and BCL2 levels. In response to cisplatin treatment alone, P53 and RBBP6 were significantly upregulated, and this was coupled with elevated levels of apoptosis. This was an interesting observation, as it suggests that there is a possible relationship between RBBP6 and cisplatin that is needed to promote cell death in HeLa cervical cancer cells. Similar gene expression patterns were seen in Cascade cells, where P53 and RBBP6 were upregulated and BCL2 was downregulated. However, the percentage of apoptosis induced in these cells was less compared to HeLa cells, suggesting that the presence of RBBP6 may limit cisplatin responses in Cascade cells. Prolonged cisplatin exposure in RBBP6 knockdown HeLa cells induced less apoptosis compared to the cisplatin-only group, despite diminished levels of BCL2. This further supports the idea that the presence of RBBP6 is needed to sensitize HeLa cells to cisplatin. The opposite was seen in co-treated Kasky cells, where a higher level of apoptosis was induced, coupled with BCL2 upregulation and BCL2 downregulation and P53 upregulation. And this also supports the idea that the presence of RBBP6 in Kasky cells limits cisplatin responses. Real-time cellular analysis revealed that the co-treated HeLa cells experienced a delayed growth inhibition compared to the cisplatin-only group in the absence of RBBP6, and a similar delay was seen in cisplatin treatment Kasky cells, where RBBP6 was present. So taken all together, we found that RBBP6 knockdown sensitizes Kasky cervical cancer cells towards cisplatin via downregulating BCL2 and upregulating P53. However, knocking down this gene in HeLa cervical cancer cells desensitizes these cells to cisplatin and limits apoptosis and prevents growth inhibition. But despite these contrasting roles of RBBP6 that we see in HeLa and Kasky cells, we can conclude that RBBP6 does have a promising role in sensitizing cervical cancer cells towards cisplatin. However, further studies on additional HPV-positive cervical cancer cells and HPV-negative cervical cancer cells can shed more light and provide more insight onto the effects of HPV infection on the function of RBBP6 in cisplatin responses. Thank you.
Shini, it's very, very interesting. You know, it's expanding community of RBP6 around the world is producing a lot of new knowledge. And I'm very curious about some of the things that you said, but we can talk about it after since we have no question time here. So the fourth one will be Daniel Francois Joubert, University of Pretoria, and the CSIR, Department of Physiology. And he is going to speak about high-throughput in silico screening for polypharmacological bromodomain 4 and cancer-associated kinase inhibitors.
Good morning, everybody, and thank you for affording me your time. So I will be going through my research project, which is on in silico screening. Which is on in silico screening of a large library of compounds to identify polypharmacological compounds from this library. Okay, so the aim was we set out to screen this exceptionally large library that the CSIR has, they own it, to see if there are any potential inhibitors in it to try and see if we could fight cancer this way. So we wanted to, our outgoing point was to look at BRD4, and then from BRD4, we wanted to look at if there might be an inhibitor of any other kinases, such as Aurora kinase A, B, and EGFR. Okay, and obviously our rationale is that cancer is a leading cause of death in South Africa, Africa, and the world, and triple-negative breast cancer constitutes 15% of all breast cancer patients, so we wanted to focus on triple-negative breast cancer. So the thing with drugs that we all know is that it usually just targets, or the intent is that it only targets a single target, a single protein, a single enzyme, a single entity, and we want to target more than one entity within cancer, specifically triple-negative breast cancer, and this might afford us a lot more time by preventing resistance developing, etc. but finding a drug is exceptionally time-consuming and very expensive, so it might be better to look at it using a computer. If we can screen massive libraries with a computer in only a few hours, we have practically one already. So the methods I used was I made use of the Schrödinger package to screen this library of 20,000 compounds. I then uploaded these jobs that I created on my computer to the supercomputer at the Center for High Performance Computing, and I got back my results. And from these results, I found 80 compounds within this library of 20,000 compounds that does seem to have activity against BRD4. And from this, I filtered it down by docking these compounds into the other kinases that I mentioned. And from this, I saw there are 10 compounds that might be usable. What I then did is I went on to an in vitro study making use of crystal violet and NTT assays to see if it does have a cytotoxic effect or at least a metabolic effect. So this is what it looked like. I had 20,000 compounds. It went down to 80 compounds. From that, 25 compounds. And from that, just 10 top hits. So my results are that I found 80 compounds that looked like they might be active in BRD4 or against BRD4. And then I saw 10 compounds is active also against Aurora kinase A and B and EGFR. And from there, I took those 10 compounds and I performed the in vitro assays. And I only found one compound to be active, or it seems to be active. And you can also see from this picture that it follows a beautiful dose-response curve, which I've never seen before in my studies. And this is what it looks like with the compound that shows this beautiful dose-response curve when it is docked into Aurora kinase. And in conclusion, I found 10 potential compounds. They look lovely. According to the docking results, it looked like we had a cure for cancer all round. But in the end, there was only one that seemed good, but also only performing MTT or crystal violet is not surefire of proof that it does work. So I need to go on with additional studies to see if the mechanisms do actually follow what I modeled on the computer. And I also need to model further to make everything look good and show that I did a lot of work. Thank you very much for your time. Thank you.
So the next one now is going to be Dr. PKP Shokwe from the University of Limpopo, Department of Biochemistry, Microbiology, and Biotechnology. And he's going to speak on the epigenetic response of MCF7 breast cancer cells to chloroform subfraction of Bidens pilosa.
Thank you. Good afternoon. I'm Khulufelo from the University of Limpopo, and I'm going to share with you part of what I did for my PhD, titled The Epigenetic Response of MCF7 Breast Cancer Cells to the Chloroform Subfraction of Bidens pilosa. Due to the increase in the incidence of breast cancer, plants are becoming more attractive as alternative treatments for breast cancer and as starting points for the development of new cancer drugs. Bidens pilosa, also known as blackjack or Spanish needle, is a medicinal plant with known anti-cancer properties or investigated cancer properties in vitro though. However, studies have not yet explored the effect of the plant on the epigenome, that is, the regulatory network that modulates chromatin or chromosome structure and gene function. Therefore, this study aimed to investigate the activity of Bidens pilosa on the epigenetic mechanisms that may play a role in the progression of breast cancer. And this was done by treating MCF7 breast cancer cells with a chloroform subfraction of a methanol extract that was prepared from the dried leaves of Bidens pilosa. And then the treated cells were evaluated for changes in telomerase activity, global DNA methylation, the cell division cycle, as well as gene expression. And from the results, it was seen that the subfraction inactivated telomerase. And because somatic cells lack the enzyme was shown to be active in 74% of breast cancers. And this would then make telomerase inactivating agents a promising approach of destroying cancer cells without necessarily affecting the normal neighboring cells. So the chloroform subfraction did just that. And furthermore, in the global DNA methylation results, the fraction was shown to increase genomic instability by decreasing the methylation of DNA that was already hypomethylated, because cancers have hypomethylated DNA, and this subfraction further decreased that hypomethylation, meaning that it increased the genomic instability, leading to arrest of the cells at the G2M phase of the cell division cycle. It's been argued that there's no arrest there, but it was a concentration-dependent arrest, slight as it was, but it was there. So this hypomethylation leading to arrest of the cells there to await DNA repair. And because the G2M phase, the G2M checkpoint repair depends on BRCA1, that repair never happened because the subfraction also decreased expression of BRCA1, shown in figure 1 over there. And that would mean that the cells would then be forced into apoptosis. I don't have the results on this presentation. But then this study, although it's still in its infancy, showed the involvement of BRCA1 downregulation in global DNA hypomethylation, leading to cell division cycle arrest and telomere shortening that would underpin the importance of epigenetic mechanisms in combating tumor progression. And the findings of this study then make Bidens pilosa an attractive repository of drug leads for breast cancer treatment, and therefore a promising herbal candidate for the development of new cancer drugs. Thank you.
The next one, the sixth one, will be by Ms. Yvette Sateche from University of Limpopo, Department of Biochemistry, Microbiology, and Biotechnology. And this one will be on the induction of apoptosis in cervical and breast cancer cells using quinoxaline derivatives.
Good afternoon. I'm Yvette Sateche, and I would like to take you through my poster presentation with the title, Induction of Apoptosis in Cervical Cancer Cells Using Quinoxaline Derivatives. And this study is under the supervision of Professor T.M. Matsabatla and Professor V.G. Mbazima. The human population has been afflicted by cancer for ages, and cancer mortality rate remains on the rise. There has been a significant shift from the common conventional cancer treatment remedies into the pursuit of finding novel anti-cancer strategies. And the aim of my study, ladies and gentlemen, is to evaluate the ability of the selected quinoxaline derivatives in inducing apoptotic cell death in HeLa cells. And from the outcome of the study, it was found that the quinoxaline in question had apoptotic effect, it inhibited HeLa cell proliferation, and it had antioxidants. Majority of the drugs that are used as chemotherapeutic agents have been associated with some off-target side effects. And with that being said, there's still a search for novel anti-cancer compounds that are specific with less probability of triggering drug resistance. Dysregulated apoptosis is a hallmark in most of the cancers, and this process is of a paramount importance since it balances cell proliferation with cell elimination. But in cancer cells, this process is delayed or rather suppressed. And once again, since apoptosis-related mechanisms are altered in cancer cells, targeting apoptosis can be an effective therapeutic mean. Kinoxaline derivatives. These are among the most recently developed compounds. This interesting group of compounds can bind DNA and induce apoptosis. So, since apoptosis evasion has been established in majority of the cancers, targeting apoptosis using kinoxaline can be an effective therapeutic mean. And as I've already ironed out on the aim of the study, we can quickly go through the methods. So in order to determine whether or not the compound in question, which is the LAM29A, whether it exhibited antioxidant abilities, the DPPH antioxidant assay was used, which is just based on the reduction of the free radical DPPH by the presence of an antioxidant through hydrogen transfer mechanism to yield a stable pale yellow DPPH. And for cell proliferation analysis, the Ki67 antigen was used as a marker to assess the percentages of the proliferating as well as the non-proliferating cells that are commonly referred to as the Ki positive as well as the Ki negative cells. And for apoptosis analysis, the Mucinexin 5 was used. And quickly maneuvering through the results, it was found that the LAM29A had antioxidant since it was able to convert the DPPH background, the purple DPPH background into that stable pale yellow. And then for proliferation analysis, looking at the proliferation graph, it was found that at 0.4 millimolar concentration, we had less expression of the Ki67 antigen, which implies that there was more inhibition of HeLa cell proliferation. And quickly looking at the corresponding proliferation profiles, it was found that we had more expression in the DMSO, which is expected, and we had less expression, at least 52%, in 0.4 millimolar concentration. And quickly looking at the apoptosis result, it was found that at the very same 0.4 millimolar concentration, we had at least 21% being induced by the kinoxaline in HeLa cells. And looking at the corresponding profiles as well, it was found that for the DMSO, we still had like more percentage of the cells that were still localized in the viable quadrant, and we had total of 21% in 0.4 millimolar concentration. And with that being said, ladies and gentlemen, the LAM29A has demonstrated to be having antioxidant abilities. It inhibited HeLa cell proliferation, and it had apoptotic effect. But to make the study conclusive, there are still other assays, experiments, as well as analysis that need to be taken or rather conducted. And with that being said, this study is still underway, and there are the, oh, this is not working, okay. And there are the sources that I've used for this poster, and most importantly, I would like to acknowledge the University of Limpopo, basically the BMBT department, the biochemistry, microbiology, and biotechnology department, and the NRF, as well as the SAMRC, and that's it from me. Thank you.
The seventh presenter is going to be Ms. Jumoke Aboyewa from the University of the Western Cape, Department of Biomedical Sciences. And she'll be speaking on gold nanoparticles synthesized using extracts of a Cyclopia intermedia, commonly known as honeybush, amplify the cytotoxic effects of doxorubicin. She's here? Online? Ah.
Yes, I'm here. Hi. Sorry, I'm trying to share my screen. Hi, everyone. My name is Jumoke Aboyewa from the University of the Western Cape. I'll just be presenting a fraction of my PhD study titled Good Nanoparticles from Cyclopia intermedia, Enhance Cytotoxic Effect of Doxorubicin in Human Colon Cancer Cells. Colorectal cancer is a term that combines colon and the rectal cancer. In 2020, colorectal cancer accounts for about 10% of the global cancer incidence and about 9.4% of cancer death. Surgery and chemotherapeutic drugs have proven ineffective for the treatment of this cancer and due to their associated side effects. So metallic nanoparticles, particularly those of biological origin, are now presently developed to offer targeted delivery of therapeutic agents in cancer cells. So this brings me to the aim and the objective of this study. The study is to synthesize and prepare biogenic gold nanoparticles from Cyclopia intermedia. It's also known as honeybush. It's a popular Southern African plant used to brew the popular herbal tea, herbal honeybush tea, known for so many health benefits. And also to investigate the anti-cancer effect of the biogenic nanodrug complex in human colon Kapoor cancer cells. So the synthesis of the nanoparticles was simply done by mixing the plant extract and the gold salt in a single-step one-pot method for the synthesis of biogenic gold nanoparticles. These nanoparticles were characterized using the UV spectroscopy, powder X-ray diffraction spectroscopy, transmission electron microscopy, and dynamic light scattering. The nanoparticles and the doxorubicin were prepared as a complex, and the biological activity of this complex was assayed in human colon Kapoor cancer cells. Cytotoxicity assay using MTT was done, and mechanistic study that involved adenosine triphosphate assay, reactive oxygen species assay, and TMRE assay for mitochondrial depolarization were assessed in the Kapoor cells after treatment. The result of the characterization showed that the nanoparticles, the biogenic nanoparticles, exhibited maximum absorption peak spectra at 540 nanometer, which corresponds to the surface plasma resonance of good nanoparticles. The X-ray diffraction analysis showed that these nanoparticles were crystalline in nature, and the TEM analysis showed that the nanoparticles were polydispersed, having a core size of 20 nanometer. The dynamic light scattering of the nanoparticles showed that these nanoparticles were stable in solution and they did not aggregate. So the cytotoxicity assay showed that the doxorubicin only reduced the viability of Kapoor cells by 10%, while a combination of the doxorubicin and the biogenic nanoparticles reduced the viability by 70%. The ATP assay showed that the combination of the biogenic nanoparticles and the doxorubicin caused a reduced intracellular ATP level in the cells compared to those treated with sole doxorubicin or the gold nanoparticles. The reactive oxygen species showed that the combination of the biogenic nanoparticles. In conclusion, the study suggests that the biogenic gold nanoparticles seem to work in synergy with drugs to enhance the anti-cancer effect of drugs in human Kapoor cells. And this was achieved through rapid depletion of the ATP levels, ROS reduction, and mitochondrial membrane depolarization. So we recommend that other colon cancer cells, in addition to other mechanistic and molecular studies, are needed to be done to unravel the full potential of this combination therapy and to know the exact mechanism of action for the reduction. Thank you so much for listening.
Thank you very much, Jumoke. Very nice talk. The eighth presenter is Ms. Mishmeyer from the University of Western Cape, again, Department of Biotechnology, Nanotechnology Innovation Center. She'll be speaking on selective elimination of cancer cells using peptide functionalized gold nanorods and photothermal treatment.
Good afternoon. I'm Michelle Meyer from the University of Western Cape. I'm a PhD student. I'm just going to share my screen. Okay, so I'll be presenting on my master's research entitled The Selective Elimination of Cancer Cells Using Peptide Functionalized Gold Nanorods and Photothermal Treatment. So nanotechnology-based therapeutics are providing solutions to the shortcomings of conventional cancer treatments. Nanotechnology refers to the fabrication, characterization, and application of active materials in the nanometer scale dimension, which is between 1 and 100 nanometers. In the current study, gold nanorods were designed with considerable control of their size, shape, stability, and dispersion properties. The gold nanorods were functionalized with a targeting peptide in order to exploit their photothermal potential for the selective elimination of cancer cells. Photothermal therapy is defined as the ability of nanoparticles to convert absorbed near-infrared light into heat and kill cells by heat shock. So we hypothesized that peptide functionalized nanoparticles would selectively be taken up by the cancer cells, and upon exposure to a near-infrared laser, the nanorods would heat up and kill the cells from within. So we synthesized gold nanorods through the seed-mediated method. We then characterized the nanoparticles with UV-vis spectroscopy, transmission electron microscopy, and zeta potential measurements. We then functionalized the nanorods with a cancer-targeting peptide known as the adipose homing peptide. We then screened a panel of cancerous cell lines for the expression of our target receptor through immunocytochemistry. And once identified, we then evaluated the cytotoxicity of the rods on the cancer cells in combination with laser treatment. So if you can see by figure 1A, this is the UV-vis spectra of the nanoparticles. So there are two peaks, which is typical of rod-shaped nanoparticles. Importantly, the second peak is above 700 nanometers, which is within the near-infrared region. Zeta potential measurements in 1B confirmed shows an increase in the surface charge, which indicates that there was modification on the cell surface, on the nanorod surface, sorry. Then the microscopy analysis confirmed the morphology of the nanoparticles and also showed that they were well dispersed in solution and did not aggregate upon conjugation of the peptide. Figure 2 shows the immunocytochemistry results of the panel of cancer cell lines we tested, and we identified 2 cell lines that expressed our target receptor, indicated by the brown stain. These cell lines were then treated with the gold nanorods and then exposed to the laser. And as you can see over here, the cell viability decreased after 5 minutes of exposure and then decreased further after 10 minutes of exposure for both cell lines. This is a preliminary study that shows the potential of peptide functionalized gold nanorods for photothermal treatment of cancer, in particularly colon cancer and prostate cancer, since CACO2 and PC3 cells are a colon and prostate cancer cell line. Thank you for your attention.
Thank you very much, Michelle, for that lovely presentation. The penultimate presentation is a case presentation by Dr. C.C. Ingo, University of Pretoria, Department of Anatomical Pathology. And this is going to be entitled A Male Malarian Tumor, a Rare Finding. Dr. Ingo.
Good afternoon, ladies and gentlemen. I'm not sure if my screen is visible. It's not showing.
Oops. We can see you.
Okay. I'll be presenting my post in a form of a case presentation. One of the interesting cases that we saw in the department, also for everyone to be aware of these cases. So it's that of a 48-year-old male patient who presented with a right testicular mass. He then had right radical orchidectomy performed, and that specimen was submitted for assessment. Macroscopically, we received a testis which measured, which weighed 73 grams in weight, and on cut section we saw a tumoral mass which was multiloculated and filled with gelatinous material. This mass measured 60 by 30 by 15 millimeters, and it had some papillary projections from it. So we then went and did microscopy, and microscopy on the first image here, it's demonstrating the testicular parenchyma, which is compressed at the periphery. Of note, we have this multiloculated tumor, which is formed by these broad-based cores, and this cores of note, they lack true fibrovascular structures. And on the higher magnification, we can see they are lined by pseudostratified epithelium, which shows mild degree of atypia, and we counted about 1 mitosis per 10 power high field. The morphology is quite classical, especially if you're dealing with a female patient, but however, our patient is a male patient, so we then went on and did immunohistochemistry to confirm the diagnosis and also to exclude other differentials which may resemble this tumor, things like your metastatic carcinomas like papillary renal cell carcinoma or malignant mesothelioma or even a serous cyst adenoma. So the immunohistochemistry that we did PAX8, we did WT1, we did ER, and they were all positive within the epithelial lining of the tumor, supporting the Mullerian type of epithelium. And CD10, we did it, which showed only positivity in the stroma, that's excluding the metastatic renal cell carcinoma. And we also then went and did the proliferative markers, which are prognostic markers, your P16 and Chi67, as well as your P53. So the P53 and P16 were negative, excluding a high-grade lesion, and Chi67 only showed low proliferative index for this tumor. So based on the morphology and the immunohistochemistry, and the fact that our patient is a male patient, we then concluded a diagnosis of a serous borderline tumor of the Mullerian type. These tumors are quite rare. They resemble those that occur in the female ovary, and they were first discovered in 1986 by Young and Scully, who studied about 11 cases. And up to date, there's only 52 of these cases reported in the world literature. Their pathogenesis is unknown. It's still controversially. Some believe they arise from the remnants. Some, they believe it's a metaplastic process that occurs within the mesothelium. However, there are mutations detected, which include the KRAS and the BRAF mutation, which were reported in about 50% of the cases that were reported. So in conclusion, these cases are not well studied and they are quite rare. So it's important to make the correct diagnosis, aided by immunohistochemistry and possible the molecular markers for optimal management of the patient. Those are my references, and I would like to acknowledge Professor M.N. Bida and Dr. Kapela. Thank you.
Thank you very much, Dr. Tengwa. Just for interest's sake, was this the first male patient with this diagnosis?
So for our department, it's the first male patient, but in the literature, they've reported 52 cases in the current literature.
Globally?
Yes.
Thank you very much for that lovely presentation. The last presentation is also a case presentation by Dr. N.P. Moyake. And he's from University of Pretoria, Department of Anatomical Pathology, and he'll be talking about an aggressive ovarian spindle cell neoplasm, a diagnostic challenge. Is that also online? Pretoria.
Mhm.
Dr. Moyake, are you ready?
Yes.
Oh
Yes,
yeah,
we're
we're
just
waiting for
sharing the
you.
screen.
Okay, welcome, and please, you can go ahead.
Thank you. Let's just leave. Okay, good afternoon, ladies and gentlemen. Similar to my colleague, Dr. Zingo, I'll be presenting my poster in the form of a case presentation of a case we encountered in the department. It was quite unique in that it was aggressive, and also the patient profile, where it was a 25-year-old female patient known with retroviral disease on treatment. She initially presented with an enlarging pelvic mass. They then proceeded to do radiological and biochemical investigations. The biochemistry showed an elevated CA1 to 5 of 208. So this is a tumor marker that is often specific for ovarian tumors. However, it can indicate other tumors that can be seen within the female genital tract, including endometrioid. It's also been reported to be high in fallopian tube tumors. We then got involved as the anatomical department when the patient had a staging laparotomy that was performed, where we saw multiple tumor nodules that were within the omentum. The radiology that was provided from us by the Steve Biko Academic Hospital Radiology Department showed a CT scan, as we can see in the poster, that showed a large abdominal pelvic mass, and it appeared to be originating from the adnexa. It was quite large with both cystic and solid areas, and its greatest dimension was 320 millimeters. We then proceeded to do the microscopy, and what we noted with the nodules that were within the omentum, they were composed of these neoplasm that appeared to be spindled in morphology. The tumor cells, however, were monotonous, with a scant amphiphilic cytoplasm, ovoid to spindled vesicular nuclei, and a dispersed chromatin. And they appeared to be arranged in an intersecting fascicle. So this morphology of intersecting fascicles and the spindle cell morphology is something that we can see in quite a number of tumors, and hence we had quite a long list of differential diagnoses for this patient. Initially, we thought of a synovial sarcoma, and we proceeded to do the molecular studies where the XX18 gene rearrangement was negative. We considered your solitary fibrous tumor because in certain areas that are not shown within the poster, we saw what we refer to as your hemangioperocytoma-like vessels. Other considerations for this patient were your GIST, commonly seen in the gastrointestinal tract, but it's been reported as well outside of the gastrointestinal tract. We considered a leiomyosarcoma, a rhabdomyosarcoma, because according to the radiology report, this tumor was already metastatic. We then did a panel of immunohistochemical studies in order to try and rule out some of the differential diagnoses that we had. In S100, SOX10, MyoD1, myogenin, CD4, FLY1, and HHV8 ruled out most of the differential diagnoses that we have. However, the positive stains that we did have was a glypican-3, which showed diffuse and positivity both in the membrane and the cytoplasm of the tumor cells. A cell4, which is a stain that is specific for your germ cell tumors, also showed nuclear positivity within the tumor cells. We then decided on the diagnosis of a yolk sac tumor, but of importance is that it's the sarcomatoid variant. So this variant was initially described in 1982 by Damajov and his colleagues, where they encountered an AFP negative tumor that appeared to have the morphology of a germ cell. However, it was AFP negative. This is often something that is positive within your germ cell tumors. So what they actually realized that this sarcomatoid variant was actually a form of differentiation of your typical or classic yolk sac tumors that we see. So all of these tumors are found positive for your glypican-3, as seen with your patients in the discussion. So a myotonic study showed that these tumors were much more aggressive in their nature, and also the treatment was not as effective. Hence, correct classification is crucial for the development of targeted therapies, which hopefully in the future can then impact the prognosis of these tumors. Thank you so much. My references are at the bottom, and I'd like to acknowledge Prof. Bida and Prof. Lockhart for their assistance with this case. Thank you very much.
Thank you very much. Thank you very much, Dr. Moyake, for that. Colleagues, I think you will agree with me that this express section was excellent presentation of concise presentations, concise, very interesting, and very fluent, and high-quality presentations, not boring at all. So I should like to thank all these presenters, 10 presenters during this session. And now we're going to go to the last section where we allow Professor Bates, whom all of you know, to give us his final comments for this conference, for the last day of the conference before the gala dinner.
Thank you very much. It gives me great pleasure to bring today's proceedings to a close before the gala dinner tonight. We've heard from a broad variety of investigators, from senior, very well-established professors through to incredibly active mid-career researchers, early career researchers, and PhD students just starting off. And I think one of the things that I'd like to take away from today is the enthusiasm and breadth of research that's going on by the PhD students and the early career researchers. It's great to see BRD4 being targeted. It's great to see alternative splicing being looked at, the variety of nanoparticle work that's going on. And to finish off with some case studies of unusual tumors is really important. We sometimes forget that the variety and the difficulty of identifying not only where the tumors come from, but what that means in terms of how its treatment requires a level of expertise which is often a bit underappreciated by some of the surgical and oncological colleagues. It's been a fantastic day for me. It's particularly, for me, it's been incredible to see the growth of the strategy and the concept behind PACRI over the last, I guess, 10 years from when we first discussed, when Zodwa first discussed the concept of a cancer centre in South Africa, which would bring together researchers from across the continent. So I'd just like to say thank you for inviting me, and thank you all for coming today, listening, for giving us the opportunity to hear about the work that's going on. And I hope this leads to lots of discussions where new research and new ideas are formulated, new research proposals are put together. Hopefully some of them will be funded and will result in significant impact in terms of change. And right the way across from the cellular and molecular and genetics, right the way through to social policy and epidemiology. So with that, I'd just like to say thank you all very much for your attention today, and I'll bring proceedings to a close. Thank you.